So good afternoon, everybody, and welcome to the workshop on the challenges in drug development, regulation, and clinical practice in immunoglobulins. So just to start, we would like to let you know that if you are not speaking, please mute your microphone, and the workshop is being recorded. So for you to be aware that the video recording will be made available on the EMA website. We will preferably take questions at the end. So we have a dedicated panel session where we can take all the questions at the end. If you do have any question, please raise your hand. You can also put it in the chat and we can also take the question. So without further ado, so my name is Caroline Vols. I work in the Office of Advanced Therapy, Oncology and Hematology at EMA. And I have started my work at EMA in 2007, so in regulatory affairs. And since 2016, I have taken the role of supporting the hematology working party. And I also co-chair the blood cluster together with my colleagues, with FDA and Health Canada. But without further ado, I would like to introduce Daniela Philadelphia, who is the chair of the Hematology Working Party. So Daniela is also the Austrian CHMP member, and she's representing CHMP from Austria. So thank you, and Daniela, over to you.
Thank you, Caroline, and welcome also from my side to this workshop. If I could have, please, my first slide. Well, you're here today to talk about human normal immunoglobulins. And in general, immunoglobulins play a crucial role in medicine and offer a wide range of indications and therapeutic options. And as you know, immunoglobulins are prepared from plasma collected from healthy donor. This is then pooled and undergoes strict controls for viral safety. And it's then followed by a complex further manufacturing process that also includes virus inactivation steps. And it's important to ensure that the products we use are safe and effective. And that's why also high quality standards are in place for manufacturing these products. And before immunoglobulins can be used, they need to obtain a marketing authorization. And in addition, it's specific for these kind of products. Each batch needs to be released by an official medicinal control laboratory before it can be put on. The focus of our workshop today is about the clinical use of immunoglobulins. And here, very generally, an overview where these products can be used. So one is to use them as a replacement therapy in patients who have an immunodeficiency. But they also play a role in immunomodulatory indications. And if there is a redefined minimum threshold of an antibody titer, human normal immunoglobulins can also be used as specific prophylaxis. Next slide, please. Well, and as mentioned, the focus of our workshop today is on the clinical aspects and the clinical use of immunoglobulins. And there are two EMA guidelines in place that define the clinical requirements to support a marketing authorization application in Europe. So in other words, these two guidelines describe the clinical data that are needed to enable a benefit-risk assessment for immunoglobulins in the scope of a marketing authorization application. And we will then hear the details of the guidelines, but as a basic principle of both of these guidelines is that data are needed, or specific data are needed in one indication that can then be extrapolated to other indications, so-called established indications. So on the one hand, for example, data are required in primary immunodeficiency, and if these data are available, then it can be extrapolated to secondary immunodeficiency. And for IV immunoglobulins, Data in ITP can be extrapolated to other established immunomodulatory indications as defined in the guideline and as defined in the applicable core SMPC. And in this regard, the guideline on subcutaneous and intramuscular immunoglobulins is currently updated. It's currently out for public consultation and will also be part of our workshop today. And as mentioned, if there is a certain antibody titer threshold in the immunoglobulin confirmed, for example, for the IVIGs, if there is confirmation of the required minimum threshold for measles antibodies, these products could also obtain an indication in pre- and post-exposure prophylaxis for measles, or the subcutaneous and intramuscular immunoglobulins need a minimum titer threshold for hepatitis A to support an indication in hepatitis A prophylaxis. What's important to note that these guidelines are regulatory guidelines, so they define the requirements for obtaining marketing authorization. These are not clinical treatment guidelines. But of course, it is important to have an understanding of the clinical use, how the products are used, and what indications play a role for immunoglobulins, and that's also one of the aspects we want to discuss today. Next slide, please. So Hematology Working Party, it's one of EMA's and CHMP's working parties, is responsible for these guidelines, and we are also responsible that these guidelines are up to date. And in our current work plan for this year, we have it defined that we want to finalize the current update and revision of the guideline for the subcutaneous and intramuscular immunoglobulins and the core SMPC. So currently we are waiting for comments from the public consultation, and we will take it into account, of course, also now from this workshop. And then we aim to finalize the guideline, the update of this guideline this year. Next slide, please. Well, and there are many different aspects and also, I would say, challenges around the development of immunoglobulins, but also around the marketing authorization, so the requirements for obtaining marketing authorization, the data that are needed for that, but also then regarding the clinical use once a product is approved. And this also includes, of course, availability, and in the case of immunoglobulins, we also need to consider the challenges arising from shortages. And for all these different steps, the development, the marketing authorization, and the clinical use, then different stakeholders are involved, and that's the reason also why we want to have and are happy to have today this multi-stakeholder workshop to discuss all the aspects with a focus on the clinical use and the clinical requirements. And even though there are several different aspects and several stakeholders, we all should have the same overarching goals. On the next slide, please. Yeah, and this is enabling patient access to medicines that are safe, effective, and of high quality. And with that, I would like to hand over to Caroline, who will explain the aim of the workshop and the outline of today. I'm very much looking forward to all the presentations and the discussion we will have.
Thank you very much, Daniela. And can I have the next slide? So, as Daniela mentioned, the aim of today's workshop is to have an understanding on the regulatory requirements for the clinical development of immunoglobulin. And this is really to support the marketing authorization. So we are not talking about treatment guidelines because our remit is really focusing on the data needed to obtain a marketing authorization. And for that, we really wanted to have clinicians clinicians, so people treating patients, perspective on the use of immunoglobulins, and also to get an understanding of their view on the established and the new indications. As you know, immunoglobulins are given in various different settings or different therapeutic indications, sometimes to treat also side effects of medicines or vaccines. So that's why we thought it's very important to have the healthcare professional perspective on its use, and also finding similarities between the use and also understanding on the posology and how these products are given. Additionally to that, we wanted to understand the perspective from industry as well as health technology assessment bodies on the use of immunoglobulins. And can I have the next slide? So for that, we have set up the workshop in 3 different parts. So the first part is really looking at the clinical use of immunoglobulins. So we will start with the first indication of replacement therapy. So looking first at the primary immunodeficiency, then on the secondary immunodeficiency. And then looking at the immunomodularity indication, and we will first start with ITP or immune thrombocytopenia, and then going into the CNS indication. So we will first have a review of CIDP as well as Guillain-Barré syndrome, and last looking at all the indication in the CNS or in the neuropathies. Then we will move on to additional perspectives. So first in perspectives from the Plasma Industry Associations, PPTA. Then a presentation from Europa Bio, given their perspective also on the clinical development and clinical use of immunoglobulins. And then a presentation from the non-for-profit sector, so IPFA, on the clinical development and clinical use of immunoglobulin. We will then have a presentation from HTA perspective. And then, as you may know, EMA has, up until recently, a new mandate on supply. And Klaus will give a presentation on the supply activities at EMA. And we will have, I hope, a very interactive panel session, really to discuss the use of immunoglobulin from a regulatory but also a clinical perspective, and then trying to understand the clinical development of the immunoglobulin. And this is in the view of updating the guideline, which is currently under public consultation. So with that, let's start with the workshop, and the first presentation is Claudia. And Claudia is part of the Hematology Working Party. So she is the rapporteur of the guideline, and she can give an overview of the regulatory expectations in terms of data needed to support a marketing authorization for the use of immunoglobulin. So yeah, Claudia Gramiccioni, over to you, and thank you very much.
Thank you. The scope of this presentation, as already told, is first of all to introduce the current regulatory requirements for the clinical development of immunoglobulins in support of a marketing authorization application. These regulatory requirements have been firstly updated for the guideline on clinical investigation of human normal immunoglobulin for intravenous administration and the corresponding guideline on core-SPC. These documents came into effect on 1st of January on 2022. The second scope of this presentation is to introduce the guideline on clinical investigation of human normal immunoglobulin for subcutaneous and or intramuscular administration and the corresponding guideline on core-SPC. As already introduced, both are actually under public consultation until the last of May 2025. And last but not least, to analyze the authorized medicinal products and their therapeutic indications. Next one. About IVIG therapeutic indications, next. The first group of therapeutic indication authorized is in replacement therapy in adults, children, and adolescents in primary immunodeficiency syndromes with impaired antibody production and secondary immunodeficiency syndromes in patients who suffer from severe or recurrent infections, ineffective antimicrobial treatment, and either proven specific antibody failure or serum IgG levels below 4 grams per liter. Next one. Next, the second group of indication is the prophylaxis for measles pre and post-exposure in adults, children, and adolescents in whom active immunization is contraindicated or not advised. In this case, the requirement is the content, the minimum measles antibody potency specification threshold of 0.36 per Center for Biologic Evaluation and Research Standard, and this criteria should be added to the product specification as required by FDA in 2018. Next one. The last group of indications is for immunomodulation, and for IVIG, these pathologies are listed: primary immune thrombocytopenia in patients at high risk of bleeding or prior to surgery to correct the platelet count, Guillain-Barré syndrome, Kawasaki disease with acetylic salicylic acid, CIDP, and multifocal motor neuropathy. Next. Here you can see a list of actually authorized intravenous immunoglobulin. On the left, you see the products authorized via centralized procedure, and on the right side, the products authorized via decentralized or mutual recognition procedure. In the notes, you can see which products have the indication also for measles prophylaxis due to the specifications demonstrated. Next one. But with the introduction of subcutaneous immunoglobulin, the attention has been equally divided between the two kinds of products. And here you can see a summary of which are the pros and the cons of the two types of products. Next one. And after the introduction, the interest for human normal immunoglobulins for subcutaneous and or intramuscular use is constantly increased. And here you can see the progressive increase of publications on the use of subcutaneous immunoglobulins, both in the group of the replacement therapy and in immunomodulation. Next. So we have conducted an update also of the guideline on clinical investigation of human normal immunoglobulin for subcutaneous and or intramuscular administration in order to be consistent where possible with the revised guideline for human normal immunoglobulin for intravenous use. And in particular, this update clarifies the indication wording of secondary immunodeficiencies and includes the indication for maintenance treatment of chronic inflammatory demyelinating polyradiculoneuropathy, and the consequent revision and update also of the guideline on CODES MPC. Next one. Therefore, this guideline describes the information to be documented when an application for a marketing authorization is made, including biological data, pharmacokinetics, clinical trials, and patients follow-up. And this applies both to products for which a new application for a marketing authorization is to be submitted, but also to authorized products where there is a significant change in the manufacturing process and new data are required to be submitted. Next one. So, first of all, biological data. Batch-to-batch consistency has to be provided in module 3 of the dossier, according to requirements of Pharmacopoeia Europea monograph 2078. And additional specific data may be needed to support the pharmacodynamic and therapeutic activities, as well as the safety profile of the preparation. The relevant data should be summarized in Module 5 of the dossier with a cross-reference to Module 3. For example, immunomodulatory and anti-inflammatory activities for autoimmune disease, depending on the claimed indications, and the relevance of an in vitro or in vivo models, such as ability to inhibit autoantibody activity in vitro and experimental autoimmune models. Next one. About pharmacokinetics, it's really relevant because it may differentiate one product from another, and therefore PK data must be provided in each application dossier. Here you can see how the trial should be conducted. So patients to be enrolled should be 40 PID patients, half of these should be children, and these patients should be or stabilized primary immunodeficiency patients on previous IG treatment or subcutaneous IG treatment, and these are called group A and B, or patients naive to therapy. Next. At the start, true levels and treatment intervals should be documented for at least 2 previous infusions in case of previous treatment, and these patients should be, after 4 months of treatment of the new SHIC products, should be assessed prior to each other infusion over a period of 6 months. The results should be compared for groups A and B with previous infusion, previous data about true levels of IgG, and for group C patients naive to therapy with literature data. Other PK parameters to be evaluated in this trial should be plasma concentration time curve, AUC, Cmax, Tmax in a subset of 20 adult PID patients assessed by repeated blood sampling after approximately 4 months of the product until immediately before the next infusion. Next. About requirements on efficacy, first of all, we speak about primary and secondary immunodeficiency syndromes. For primary immunodeficiency syndromes, an open-label, single-arm clinical trial is requested of 1 year duration due to the necessity to avoid seasonal bias in at least 40 patients with PID, and we should enroll the same patients used for PK study. Approximately half of the patients should be children and adolescents. The primary efficacy objective is the rate of acute serious bacterial infection that should be less than 1 person per year. Secondary endpoints are PK parameters and all other infections, antibiotic treatment, days lost from school or work, hospitalization, and fever episodes. The efficacy results obtained in a study with primary immunodeficiency will apply to all types of primary immunodeficiencies. Next, and if efficacy is proven in these patients, indication is granted automatically also for secondary immunodeficiencies. Next. So the corresponding updates apported to the guideline on clinical investigation regard the section 4 and the corresponding section 5.3.2, and the rationale for this update was according to the current guideline for human normal immunoglobulin for intravenous use, but also according to what already evaluated and authorized for several subcutaneous immunoglobulins that independently submitted the specific variation procedure via centralized or decentralized procedure. Next. And corresponding, there was the update of the CORES MPC in section 4.1 with this indication of for secondary immunodeficiencies, and the corresponding posology is added to section 4.2. The posology has been established on the basis of cumulative monthly dose of EVIG considered protective in the same indication, and also according, also in this case, to what already evaluated and authorized for several SHIG in the frame of specific previous procedure. Next. The second group is the efficacy in immunomodulation. Actually, they are the only demonstrated immunomodulator indication for subcutaneous immunoglobulins based on data derived from phase 3 clinical trials is the maintenance therapy of CIDP. The other immunomodulator indications for intravenous immunoglobulins are not yet approvable for subcutaneous immunoglobulins since no data are available. Next. So if the efficacy in PIDs is established, then extrapolation to maintenance therapy for CIDP possible without perform separate clinical trials in this indication if adequately justified. the dosage regimen should however be justified, and if a dosage regimen different from those added to guideline on CORES MPC are requested, they should be supported by relevant clinical data. Next. And also in this case, you can see the updates to the guideline on clinical investigation in section 4 and corresponding in section 5.3.3. And the rationale of this update is the inclusion of CIDP as already introduced on the basis of phase 3 clinical trials. The other established immunomodulator indications are actually not yet established for subcutaneous immunoglobulins. Next. The corresponding, and also in this case, the corresponding update on CORES PC involved the section 4.1 and section 4.2 for the introduction of the posology. The posology has been established according to what already evaluated and authorized in specific procedures via the centralized or centralized procedure. Next one. The last group of indications, in this case for intramuscular use of immunoglobulins, is for the prophylaxis of infection. In this case, if minimum antibody content for HIV of 100 international units per ml is foreseen, it's also used in adults and children and adolescents for pre-exposure prophylaxis in combination with vaccination in unvaccinated individuals traveling in less than 2 weeks to areas at high risk of hepatitis A, and in post-exposure prophylaxis in individuals within 2 weeks of hepatitis A virus exposure. Obviously, for long-term hepatitis A prophylaxis is recommended the vaccination. For this indication, it's not necessary to provide specific clinical data for the product, but the monograph for human normal immunoglobulin should be added too. Next. About safety, these are the data that should be provided. The analysis of adverse events and serious adverse events from clinical studies should be recorded and reported with particular attention to causality, seriousness, severity, outcome, and expectedness. Monitoring of short-term and local tolerance and at repeated intervals after the infusion. Separate evaluation of the safety dataset in children and adolescents to be compared with the adult dataset, and relevant discrepancies should be listed and reported in the SMPC. Post-marketing safety data in children should be requested in the risk management plan. Separate safety evaluation of the excipiency should be conducted. And about viral safety, reference should be done to note for guidance on plasma-derived medicinal products and the corresponding guideline on the warning on transmissible agents in SMPC and package leaflet for plasma-derived medicinal products. All available data obtained on patients treated in clinical trials should be provided, and the same principles applies now to all transmissible agents, including emergent pathogens and TSE. And last but not least, the effect of passive transmission of hemagglutinins such as anti-A, anti-B, and also anti-D should be evaluated by searching for hemolysis via a direct cum test. Other changes that have been applied in the frame of the update of the guidelines are in the section dedicated to new products. The update has already introduced of section 5.4.4 about other transmissible agents, and in section related to product already authorized, a specific requirement of biological data, since the effects of changes in the manufacturing processes on the biological characteristics and activity of the product should be investigated, and therefore is underlined that it's important to provide full data on antibody integrity and function as for new products. Next. Furthermore, formal update of sections 3, 5.4.1 and 7 have been applied. Next. And other changes on the guideline on Code SMPC involved all the sections listed in this slide. In particular, I would underline the update in section 4.8 on the table for the reporting of adverse events from clinical trial, where the frequency has been extended not only to the number of patients, but also to the number of infusions. Next. And formal revision of all section and review by QRD members to be in line with QRD template has been conducted. Next. Only a brief information on the main comment during arose during the GCG revision. It was requested to consider the possibility to completely delete the intramuscular administration of these products because considered outdated. This proposal has been deeply discussed by the drafting group, and it was considered not acceptable for the following reasons, because even the intramuscular administration of this kind of products is considered still useful in some conditions, such as, for example, as already introduced in pre and post-exposure hepatitis A prophylaxis and international travelers, as reported also in ACIP recommendations. And this is actually an authorized therapeutic indication for this kind of products if the immunoglobulin has a minimum antibody content for HIV. Therefore, this route of the administration has to be considered still valid in some circumstances, and also because there is already a warning at the end of section 1 reporting that in other therapeutic indications the intramuscular route of administration is considered not the best way to give the drug because there is excessive and unnecessary discomfort for the patient. There is no need to completely delete the intramuscular administration. So also in this case, you can see on the left centralized procedures authorizing subcutaneous intramuscular immunoglobulins, and on the right side, the centralized and mutual recognition procedures. As you can see, these are the products Iaizentra, IQVIA, and Cutaquig have already updated the therapeutic indications before the update of the guideline with specific procedures. To note that Cutaquig has been updated about the secondary immunodeficiencies, but not for immunomodulator indications. Thank you very much.
Thank you very much, Claudia. And now we can move to session 2 with all the presentations of our clinicians. And our first speaker is Maria Pria Cipcalese. She is a physician scientist at the Pediatric Immunohematology Unit in San Raffaele Hospital in Milano and San Raffaele Telethon Institute for Gene Therapy. So her clinical and scientific interests are mainly with the diagnosis and management of patients with primary immunodeficiency and also the discovery of new genes causing PID and gene therapy. And she's also an assistant professor of pediatrics at the University Vita Salute San Raffaele. And the floor is yours for your presentations on the use of IgGs in PID.
And first of all, nice to meet you all, and thank you for the opportunity to discuss this topic for the benefit of the European community. So I'm waiting for my slides. Okay, thank you very much. So next slide, please. Okay, I have no disclosure for this presentation. Next, please. Okay. So first of all, I would like to introduce you to primary immune deficiency. That comprises an heterogeneous group of more than 480 diseases that affect adults, children, and neonates, and that are genetically determined. So the natural history of primary immune deficiency has dramatically changed by the setting of neonatal screening that is universal now in the USA, and that has been established also in many countries in Europe and also in Latin America. So in this cake, you see that the predominantly antibody deficiency accounts for the highest relative frequency within the group of PIDs, accounting for 55%, followed by combined T and B cell immune deficiency that account for 11%. And I want to stress that for both these conditions, the use of immunoglobulins is mandatory because it's documented in the number, in the level of IgG, but we also use immunoglobulins for other conditions of defect of the immune system, as the effects of immune dysregulation due to inflammatory diseases, as we document an impaired level but also quality of antibodies, and we use immunoglobulins also to manage some immune dysregulatory features. So next slide, please. Okay, so in the field of primary antibody deficiency, you know, that is the largest part of PIDs. This slide accounts for the major groups of primary antibody deficiencies, including CVAD, hyper-IgM, and XLA or Bruton disease, for which you can see on the right that the immunoglobulins are a standard of care and are definitely mandatory for managing the complications of these disorders, but we also know that the use of immunoglobulins is considered for some quite severe cases of transient hypogammaglobulinemia of the infancy. That is a transient condition given by an inadequate secretion of antibodies by B cells. That is again transient in the newborns, but still immunoglobulins can help. So what is very crucial for us is that the involvement of the patient in the treatment process, including immunoglobulins, of course, is very crucial since the beginning. So the role of this group of physicians should be to explain the patient about a patient-centric care that should aim at individual, customized and flexible treatment regimen, including the use of immunoglobulins. So we also understood the difference between patient compliance and adherence, and this is very crucial for long-term, again, adherence to immunoglobulin regimen, because compliance implies a passive behavior to instructions given by clinicians, while adherence emphasizes an active patient engagement and partnership with clinicians. And we have to aim, of course, to enhancing flexibility and convenience of this treatment regimen in order to again, optimize the patient adhesion to our indication and the regular monitoring, of course, to therapies. So next slide. So what about the potential mechanisms of action of immunoglobulins in PID? So the full mechanism of action is still not fully understood, but we know that immunoglobulins play at different levels. So at the level of B cell, interfering with the BCR signaling and down-regulating CD21 expression, for example, at the level of CD4 T cells, reducing activation and exhaustion markers, as well as inducing Tregs that are really crucial in promoting self-tolerance. Immunoglobulins play at the level of monocytes, regulating magnitude of monocyte activation and inflammation, as well as the impact on the development of dendritic cells, while no effect has been reported at the level of polymorphonucleates. Okay, so what about the use of immunoglobulins in PAD? So the indication, as already explained by Dr. Gramiccioni, is the use of intravenous immunoglobulins for PADs with absent or deficient antibody production. So we have, again, PADs with very low, minimal to low total IgG levels in circulation, but we have also conditions with an impaired quality of antibodies. The frequency of treatment is, of course, definitely continuous replacement therapy without possibility of interruption of this therapy, and the dose. So the starting dose accounts for 400 to 600 milligram per kilo every 3-4 weeks of IV IgG, while less frequent treatment or use of lower doses is not substantiated by clinical data. So what about the IgG throw levels? They can be very useful in some diagnosis of PAD for guiding the dosing strategies, but should not be a consideration in access to EVIG therapy. So the site of administration of EVIG is up to the physician and the patient's need. I mean, intravenous immunoglobulin, of course, has to be performed in as inpatient, of course, but also the use of other formulation home-based, of course, have become very popular and at the moment. So the route of administration must be based on patient characteristics. So most of the patients with PADs are appropriate candidates for intravenous administration, and a subset of patients for subcut administration. While the common active component of IgG, of immunoglobulins product being an IgG, but with differences in formulation that can impact on, the occurrence of adverse events, for example. Next slide, please. Okay, so a very crucial point is the pharmacokinetic profile for various formulation of IgG. So we all know that pharmacokinetics aims at evaluating the safety as well as the efficacy of a drug component based on the absorption or on the volume of distribution, on the clearance, and on half-life and accumulation that are changing subject by subject and in line with different formulations, of course. So for IVIG, we know that the peak of pharmacokinetics occurring very early, so on day 1 after administration, while it's a little bit slower for subcut IgG occurring between day 2 and 4, and in line with also facilitated subcut IgG, and we will talk about it in a while. And in case of facilitated subcut, the PK profile is quite stable, even on the days and the weeks afterwards. So next slide. Okay, we all know about some quite differences between let's say the 3 formulations that are available at the moment. So EVIG, subcut, regular subcut immunoglobulins, and facilitated subcuts immunoglobulins. So the main differences are for EVIG administration, the need to provide for an infusion every 3-4 weeks. We can administer large volumes. The time is quite long of the infusion, of course, and the patient will need an hospitalization, and the occurrence of systemic reaction is possible, so has to be taken into account. Whilst for subcut, we have a more flexible schedule of administration, ranging between daily administration of small volumes up to every 2 weeks administration. The patient is very comfortable in doing it at home locally. So the cost is quite low. The occurrence of local reaction is more frequent than systemic reaction, and these are the main differences. So for facilitated subcut immunoglobulins, again, we have more local reactions, so more similar to regular subcut, with quite rare occurrence of systemic reaction, but the costs are quite low. Next slide, please. So the dosing of conventional subcut IgG, so they are very convenient to both patients and healthcare professionals, of course. So they are preferred in a certain categories of patients, as patients at a thrombotic risk or with poor or difficult venous access, in, for example, infants and small children, or adults with compromised venous access or in need to preserve access, for example, patients undergoing chemotherapy, or in case of previous systemic reactions to IVIG. So in the PID patients, we typically initiate with IVIG and then switch the patient to subcut with the initiation of treatment 1 week after the last IVIG infusion. So again, the dose and dosing frequencies is ranging from daily to every 2 weeks, and the dose is established by converting the monthly IVIG dose to the equivalent weekly dose and increasing up to using an adjustment factor that is 1.3, 1.5, as indicated by FDA, while in Europe no dosing conversion factor is established. We know that higher IgG throw levels are beneficial to PID patients. Indeed, higher doses are used for the treatment of serious bacterial infections, even subcut. And as per summary product characteristics by EMA for PIDs, the dosage regimen should achieve a sustained level of IgG, and a loading dose of at least 0.2 to 0.5 gram per kilo body weight must be required to be divided over several days, with a maximum daily dose of 0.15 gram per kilo. And after steady state IgG level, a maintenance dose is set to 400 to 800 gram per kilo. To be performed at repeated intervals. So there are some caveats, as absorption is low compared to VIG, and larger doses and large volumes cannot be administered. Next slide. So what about the recombinant human hyaluronidase facilitated subcut IgGs, 10%? So these are approved for the treatment of PIDs in adults and children aged above 2 years in USA, and in patients of all ages with PIDs in Europe. We have a dual vial unit, one vial containing IgG 10% and the other one containing recombinant human hyaluronidase, which basically depolymerize hyaluronan in the extracellular matrix, increasing the permeability of the subcut tissue to IgG. So this is associated with an increased bioavailability. So the pros are, again, the higher volumes and higher doses can be administered. We know that area under the curve of facilitated subcut IgG is quite similar to IVIG. The initiation of this treatment requires an initial dose ramp up to achieve the target dose dose. So we start with 25% of the target full dose at week 1, then 50% in week 2, and then 75% in week 4, and eventually with 100% of dose in week 7. And then a maintenance dose of 300-600 milligram per kilo, 3 to 4 weeks intervals should be administered. Next slide. So what about IgG true levels? So this is very crucial in guiding the dosing of patients with PIDs, but this cannot be the only element to prove of the treatment. So we know that, of course, for pneumonias, for example, the incidence of this infection with the IVIG maintenance of 5 grams per liter, IgG true level is 5-fold higher than in patients with 10 grams per liter, so demonstrating that the risk of pneumonia could be reduced by achieving higher IgG true levels. So, and also in an evidence-based review of 25 studies in which patients with PID were administered with IVIG or subcut IgG, it was revealed that IgG true levels were higher with subcut administration than with IVIG administration, but both the routes of administration were efficacious for protection from serious bacterial infection. And we also know that in a meta-analysis assessing the IgG true levels and the efficacy of EVIG and subcut IgG treatment for PIDs, for every 1 gram per liter increase in IgG true level, a linear trend for decreased incidence of infection was observed in subcut IgG patients. So the true levels of IgG are highly relevant surrogate marker for therapeutic efficacy of IgG in primary immune deficiency, but still there is an interpatient variability related to the protective threshold that is absolutely individualized and that should drive our decision on the frequency and dose of administration. Next slide. So there are specific populations requiring peculiar dosing strategies, even if there are still no sufficient data to draw conclusions. For example, children, neonates, adults, geriatric and obese patients. So still there are no recommendations for dose adjustment in this population, but we know that body mass index composition may affect how IgG is absorbed, distributed and eliminated, and at the moment decision of the dose of EVIG should be based on ideal body weight in this patient rather than on adjusted body weight, in order also to spare money and to reduce resources and economic burden of the health system. And while in IG naive PIDs patient, the lower the baseline IgG level, the higher the loading and maintenance doses required, and the longer the time to achieve the target level should be. Okay, next slide. So as we saw, there are still open issues. So the variability in PK in patient clusters and in peculiar population that should need individualized dosing strategies, and also for IgG naive patients, IgG dosing guided by target, IgG true levels that should be studied in peculiar patients population. We have also some potential issues of immunogenicity. So that is based on anaphylaxis for AVIG administration and on the production of non-neutralizing antibodies. And we have also a matter of the possibility of passive transfer of autoantibodies that is particularly true for patients with primary immune deficiency, and that could lead to misdiagnosis of autoimmune disease in this patient's population. So next slide. Okay, so this is a very nice study I wanted to briefly show you that is describing the behavior of a Spanish hospital in COVID pandemic with global EVIG shortage that allowed to start this study, recruiting adult PID patients on subcut IgG for at least 6 months with IgG throw levels above 700 milligram per deciliter and no history of significant infections in the past 6 months. So to these patients, it was proposed a dose reduction of 15 milligram per kilo per week, so around 60 milligram per kilo per month reduction with monitoring of clinical and laboratory data and with monitoring of infectious event at baseline and then 6 and 12 months of follow-up. So 31 patients with primary antibody deficiencies basically were enrolled and no significant change in severe or mild infections before and during the follow-up observation period were detected. So this dose reduction saved an average of more than 5,000 euro per patient annually. That accounted for a spending review that was very crucial for the hospital. So next slide. And then this paper is describing a new method for preparing lipid-enveloped virus inactivating immunoglobulin solution from mini pools of domestic recovered plasma, and the safety and efficacy of this product was tested as a replacement therapy in 21 pediatric PID, displaying a safety and efficacy profile quite equivalent to the standard intravenous immunoglobulin preparation, paving the way to potential custom-made preparations. Next slide. And last but not least, these last two are two studies evaluating the quality of life and the perception of well-being in patients treated with EVIG versus subcut EVIG. And apart from the sparing time of infusion, there was an overall positive perception of freedom and well-being in the population treated with subcut, of course, and the heat map on the right also demonstrates that the adverse events were basically mild and local. Next slide. And again, in this cohort, also the impact of immunoglobulin infusion on work and school attendance of this population and quality of life was demonstrated and promoted as satisfactory for patients undergone subcut, regular subcut and facilitated subcut immunoglobulins versus EVIG. Next slide. So in conclusion, human immunoglobulins products are a standard replacement therapy to restore and maintain stable levels of IgG for clinical management of patients with PIDs, and this require a patient-specific and individualized administration schedule, and the monitoring of IgG levels is an integral part of the diagnostic path of PIDs, and the adjustment of the levels of IgG and treatment schedule should be needed for every single patient. And the use of subcut treatment can be considered also ab initio in patients newly diagnosed with PID, and substantial variability in the pharmacokinetics and clinical response to IgG therapy have led to the proposal of individualized therapy for maximizing the therapeutical benefit of this approach. Next slide. So I've done. Thank you very much, and I will be happy to get your questions.
Yeah, thank you very much. We will take all the questions and further discussion then in the panel discussion at the end of the workshop. And I would like to introduce you our next speaker, who is Peter Asdal from the Aarhus University Hospital in Denmark. Peter is a senior consultant and working primarily with hematopoietic stem cell transplantations, acute leukemia and infections among the hematological patients. And today he will talk about the use of immunoglobulins in secondary immunodeficiencies. So Peter, the floor is yours.
Thank you very much. I hope you can hear me.
Yes, we can hear you well.
Great. So thank you very much for the invitation to give my take on the title, Clinical Considerations on the Use of IgG in Secondary Immunodeficiencies. Next slide, please. On this topic, I have no conflicts of interest to declare. And the next slide. So there are many causes of hypogammaglobulinemia, and they can simply be divided into disease-related factors, which is typically related to the malignant clone suppressing B cells or plasma cells, or they can be treatment-related. And specifically, the treatment-related factors are, in my opinion, a main cause of the rise in the demand of immunoglobulin worldwide. They include monoclonal antibodies targeting B cells and plasma cells, and the newer therapies, CAR T cells and bispecific T cell engagers, but also patients receiving conventional chemotherapy, typically those who are lymphocyte directed, and particularly patients that has received more lines of therapy. To some extent, also patients receiving long-term high-dose steroids, and then patients who has received bone marrow transplantations or hematopoietic stem cells transplantation, particularly allo transplantation, and particularly those with GVHD. Next slide, please. So to set the scene, I'd like to start off with a recent case of ours. This is a 62-year-old male with chronic lymphocytic leukemia. He has received numerous lines of therapy for his leukemia, including bispecific T-cell engaging therapy in a trial setting. He's been transplanted 1.5 years ago, and he has now chronic GVHD, which is well controlled on immunosuppressants. 3 years ago, he also had hypogammaglobulinemia and recurrent pneumonia and was therefore started on IVIG treatment in a standard dosing. Unfortunately, shortly after initiation of this, he had an episode of aseptic meningitis, which is a very rare complication to immunoglobulin therapy, but also well described. Currently, he has had a low IgG level for some time. The most recent one was 2.9, so at least under 4. He had received a standard vaccination program following his transplant, and he's on our standard prophylactic pneumocystis prophylaxis when on immunosuppressants. But then he was admitted with very severe bacterial infection and pneumococcal septicemia, pneumonia, but that was well treated, and then we decided to start him, even though he had had the aseptic meningitis, we started him on facilitated subcutaneous IgG in a standard dosing, and he has now been free of infection at least for the past 4 months, but we hope this will help him further. Next slide, please. The aim of treatment with immunoglobulin in this setting is, of course, infection prophylaxis. And so we would normally expect from a treatment like that we had great documentations of a number of things, including a reduced infection and all-cause mortality, reduced rate of infection, both severe and any infection, a reduced rate of admissions and bed days used, reduction in the use of antibiotics, and also improved quality of life. Next slide. However, the documentation in secondary immunodeficiency is very limited. So this is a figure from a recent meta-analysis, Chai et al. From Blood Advances in 2023. And I'd just like to draw your attention to the blue box with a red line around it, which shows that only 8 clinical trials were identified, and 7 of these were published more than 25 years ago, and we must say have been treated according to very different treatment protocols as we would use today. They find that the rate of clinical documented infections is reduced by 28%, but there were no effect on survival. Next slide, please. And then further, I'd like to just shortly show the results of a very recently published study from Australia, in which they randomized patients with low IgG between antibiotic prophylaxis with sulfamethoxazole and trimethoprim versus IgG substitution. And in this study, without digging firmly into it, I'd just like to say that they find no difference between the group in the rate of infection. Also have to highlight that this is a rather small study that was not powered for this, and the conclusion is also that the findings is feasible for progressing into a larger phase 3 trial. So limited number of trials so far. If you go through clinical trials, there are studies coming out, but there are few. In particular, I'd like to mention an interesting study, in my opinion, that is coming from the Fred Hutchinson Cancer Center, where they investigate IgG substitution versus placebo in a randomized setting in people receiving CD19 CAR T cells. But unfortunately, I think it will be at least a couple of years before we have the result of that trial. Next slide, please. So what do we know if we go back to my later post requirements? Well, there are no studies that show any benefit on either infection-related or all-cause mortality. There do seem to be an effect on the rate of infection, both severe or any infection, reduced admission rate, a reduced number of bed days used, also a reduction in the use of antibiotics. But when we went to the literature 2 years ago, only found one study that looked at quality of life, which seemed to be better, but not necessarily in a satisfying way. So you would actually think it meant a clinical benefit. And overall, the documentation for this is poor. Next slide, please. So with poor documentation, I believe it's important to avoid over-treatment and reserve treatment to those with a solid indication. But who are they? You can go for primary prophylaxis and treat based on IgG levels alone. Then you'll, in my opinion, treat many patients. But if you extrapolate from primary immunodeficiency, as we have just seen, some results might support that. But at which level would you want to go then? Below 2, 4, or 6 maybe? Then you can also go for secondary prophylaxis, so both see a low IgG and recurrent infections. But how many infections and how severe? And should you have tried antibiotic prophylaxis first? At my institution, we have earlier used a very liberal approach, but has now gone through a phase where we discuss every patient at a multidisciplinary team conference to make sure that we select the right patient for IgG substitution. Next, please. So approaching the end of this talk, I'd like just to draw attention to a problematic trend in the use of IgG. And I won't go detail through these statements here, but the first paragraph is from a recent myeloma trial on a bispecific T-cell engager. And here the sponsor insists on the use of IgG as primary prophylaxis, and without doubt, most patients with this kind of bite will fall below 4 grams per liter. As a backup for this statement, there's a reference to a consensus guideline, myeloma consensus guideline, where it is stated that in this setting, every patient with an IgG below 4 should be substituted. And again, that is actually referenced only to a single study, which is a retrospective study of 37 myeloma patients. So again, it's problematic that it becomes opaque to how poor the evidence for the use of IgG is in this setting, and it encourages through the use of IgG in almost every myeloma patients going through a treatment like this. Next slide, please. So some important issues that could not be part of this 10-minute talk, but I'd like to mention that there is a focus on them in, for instance, the European Hematology Association, which is, for example, the dosing of immunoglobulin, route of administration, alternative prophylaxis, including antibiotics, duration of therapy, and also if it's safe to have summer pauses. And I won't go through them, but I'd be happy to discuss them during the panel discussion if there's an interest for this. And then the last slide. Yeah, and so with a picture of a hopefully upcoming spring here in Denmark, I'd like to conclude with that IgG substitution reduces the rate of infection, but has no effect on mortality. And I believe patient selection is important, and that we need trials in populations treated on contemporary treatment to know more about the efficiency of this treatment. Thank you.
Thank you very much for this focused and concise presentation. And indeed, we may come back to some of the questions that are indeed relevant during the panel discussion. Our next speaker is Jan Svaginger. He is a professor in clinical transfusion medicine at the Department of Hematology of the Leiden University, and he is also chairman of the university's blood transfusion committee and chair of the Benign Hematologic Diseases Working Party at the Dutch Hematology Association. And he will talk about clinical considerations on the use of IgGs in ITP. The floor is yours.
Thank you very much, and thank you for the invitation to talk about the use of intravenous immunoglobulins in immune thrombocytopenia, ITP. And if time permits, I will also tell something about the use of IVIG in fetal-neonatal alloimmune thrombocytopenia. My talk is also on behalf of Professor Masha de Haas of the Dutch blood supply organization Sanquin, and I have no conflicts of interest for this talk. About ITP, what is the problem in adults? It's a pretty rare disorder. You see here the incidences and the prevalences, but in the Netherlands it translates in about 400 new patients per year. and we talk about thousands of new patients Europe-wide. The disease manifests itself by bleeding symptoms, and in chronic course, when bleeding symptoms and platelet numbers are managed, we often see a severe reduction in quality of life. In children, ITP mostly reveals itself following infections, but in children, it's mostly a limiting disorder, and 80 to 90% of patients recover within a few months, leaving only 10 to 25% of children which have a chronic course. If you look at traditional pathophysiological concepts of ITP, ITP hinges about the autoimmune antibodies, which are directed against various epitopes on platelet membrane-expressed glycoproteins, and decorating these platelets with these autoantibodies fastly induces their clearance in the spleen. But also these antibodies probably have effects on the production, and some antibodies are also reported to have reduction in the platelet functionality. I hear some background noise, so maybe everybody can mute his microphone. So bleeding, here you see some manifestation of the less serious skin bleeding, on the left petechiae, and more serious skin bleeding ecchymosis. But as clinicians, we mostly fear the wet bleeding, like epistaxis with considerable blood loss, and the very much feared, of course, intracranial hemorrhages, of which you see here an CT image. And together, these more serious bleeding amount to about 10% of patients. But they are mostly seen at very low platelet counts, below 30. Normal for us here as audience is about 250. And most serious bleeding are seen in the elderly patients and are associated with the length of and the depth of thrombocytopenia. So the management of acute bleeding treatment is now for the IVIG the subject, but you could also give in that case high-dose corticosteroids, which have the advantage that you also modulate the disease in about 50% long-term. IVIG has a maximum of 2 weeks effect, but the effect and why we do it is clear from this figure, that with IVIG, you can, within 1 or 2 days, you can raise blood platelets in most patients up to counts above 50, which is a level which often reduces all bleeding. If you give corticosteroids, that takes you that same level of platelet counts. You can reach it, but it takes more days. And of course, if you give IVIG and corticosteroids together, the effect is synergistic. So I think Peter already told something about it, or another speaker, but immune globulins work via the macrophage. There are a lot of effects, but on the macrophage, where the clearance of autoantibody decorated platelets are cleared, the macrophage by IVIG changes into a more inhibitory phenotype. But also IVIG probably has effects on the clearance of autoantibody via the vascular wall, and it also is able to modulate the production of autoantibodies. So what about the dosing we use? In earlier days, very high doses were used of 2 grams, not milligrams, but 2 grams per kilogram, divided often into 1 or 5 days were used. But using lower doses, but still high doses, was shown in meta-analysis and several randomized controlled trials to not reduce the effectivity of about 80+%. And of course, very important, the cessation of bleeding in days was not inferior when you use a lower dosing of IVIG. What is important if you use lower dosing is that the side effects, which are often low grade and often easily managed, reduce from 6 to 3%. But using lower dosing also decreases the severity, not only the frequency of side effects, it also reduces the severity of side effects. In children, somewhat lower doses are used, and also the effectivity rate of these lower doses, 0.6 to 1 grams per kilogram, is similar to the very high doses as we just mentioned, with even higher effectivity rates of 90+%. And also here you see that the adverse event rate is also reduced by using lower dosing. A very interesting trial, a bold trial from Dutch investigators, was to test whether we could also observe bleeding patients, ITP patients. It's a children trial. They randomized 200 children 1-to-1 in observing them, close observing them, versus giving intravenous immunoglobulins in the mentioned dose. And the patients which were included, the children patients which were included, all had some bleeding. And in the guideline up to that time, there was a matter of mild and moderate bleeding. You could watchful wait. And of course, the interesting factor is whether a bit more severe bleeding could also be expectatively treated. These are the results. Of course, the cohort which received IVIG showed a vast increase of platelets as opposed to the observed group. But if you looked at the grade 4 bleeding, you had to treat 100 patients with IVIG to save 8 more serious bleeding, of which 1 was intracranial. So that leaves us with a discussion. An interesting thing, of course, to say is that the more chronic course of ITP in children was not influenced by giving IVIG as opposed to observation. But this leaves us with about the same guidelines for using intravenous immunoglobulins in the given doses I just talked about, as we had in 2014. But maybe we should more specify that not only a high risk for bleeding is an indication for IVIG in ITP, but we should really have clinical relevant bleeding, more serious bleeding. We should not use it for every intervention or surgery, but only for intervention and surgery which cannot be postponed. So summarizing, IVIG in ITP has a fast and, in the majority of patients, increase in platelets and hence restores hemostasis in that respect. But the very low incidence of serious bleeding, even without intervention, the IVIG's reversible effect, the costs, and of course the adverse events which are associated with IVIG suggest that the more restrictive use of IVIG in ITP is justified, although this has not been evidence-based in adults, and only the data from the children trial I just showed you are available. A short detour about fetal neonatal alloimmune thrombocytopenia. This is the interesting mechanism that a mother lacking a human platelet antigen can come in contact with fetal blood on which paternal human platelet antigens are present, which are recognized by the mother, forming anti-HPA antibody, which can transfer through the placenta back to the fetus and destroy the fetal platelets there. And this can result into a very, very severe bleeding with intracranial and organ bleeding, which, if it occurs, has a very high fetal mortality, and in case of intracranial hemorrhage, also severe neurodevelopmental impairments. About 2 to 3% of the white ancestry population are HPA deficient. So these females, when they're pregnant, they, of course, have a very high chance to have a partner with HPA-1a, can form these anti-HPA-1a antibodies with these hemorrhage in the fetus as an effect. And immunization causes severe bleeding in a very low percentage, but it can be very debilitating in these HPA negative women at risk. So this has resulted in a more or less guideline, especially in the Netherlands, is that if once a female has had a pregnancy with a FNAIT with intracranial hemorrhage, she will immediately be treated with a high dose IVIG from the 16th to 18th week of pregnancy. But then again, if such a female has not experienced a pregnancy with intracranial hemorrhage, antibody titers will determine whether in the Netherlands IVIG is given in a somewhat lower dose to these females also at risk for severe bleeding in FNAIT. And the last thing I would like to say is that if we test pregnant women for anti-D antibodies, we could also test them as a screening for HPA 1a antibodies. And in this way, we could have a preventive strike, and maybe this will be cost effective. This concludes my presentation, and although I have this slide for questions, I think we should leave that to the panel discussion.
Thank you very much. And indeed, we can come back during the panel discussion. Our next speaker is Yuri Falzone. He's from the San Raffaele Scientific Institute in Italy. He graduated in neurology, and he's mainly focused on the clinical management of patients affected with neuromuscular disorders. And he will talk about the use of IgG in CIDP. So the floor is yours, please.
Thank you, Daniela, for the presentation invitation. My talk will focus on the clinical use of immunoglobulins in inflammatory neuropathies. Next slide, please. These are inflammatory I have no conflict of interest to declare concerning this presentation. Inflammatory neuropathies belong to a wide disease spectrum embracing several autoimmune neuropathies. Among them, we have Guillain-Barré syndrome, or GBS, representing the most common acute variant, while chronic inflammatory demyelinating polyradiculopathy, or CIDP, represent the most common chronic variant. If left untreated, both these conditions lead to significant disability or mortality. Therefore, timely immunomodulatory treatment are essential in management of this patient. Next slide, please. Let's start from the GBS pathogenesis that is not fully understood. However, we know that most of the patients report an infection occurring some week before the neurological manifestation. It has been proposed that molecular mimicry between bacterial, viral, and neural antigens play a key role in the development of the pathogenesis. We know that both humoral and cellular autoimmune responses are activated, leading to the generation of autoantibodies and autoreactive T cells that cross-react with myelin and axon antigen. Macrophages culminate this cascade attacking the nerves in axon and in myelin epitopes. Next slide, please. From a clinical point of view, GBS is a severe syndrome characterized by progressive muscle paralysis that may lead to respiratory failure. As quite clearly depicted here in the image on the left, GBS is a monophasic disease. Neurological symptoms reach a nadir typically within 2-3 weeks, and then there is a spontaneous recovery phase that can last several months. Mortality and significance, as we said, are extremely important among these patients. Therefore, administering timely immunomodulatory therapy is essential and has to be done in the acute phase. Otherwise, they can be ineffective. Next slide, please. So the first treatment that was approved for GBS was plasma exchange in 1987, and all the clinical trials that explored the efficacy of IVIG were compared to plasma exchange. The dosage that was used in the clinical trials was 0.4 gram daily for 5 consecutive days, and the patients that were enrolled were non-ambulatory patients with a disease duration shorter than 2 weeks. This is the results published from a Cochrane meta-analysis that was published in 2014. The authors pulled together all the information coming from the randomized clinical trial that explore and compare the efficacy of these two treatments. The authors concluded that there were no differences in short and long-term outcome measure. Therefore, in light of these results, IVIG are currently considered a therapeutic indication for GBS. Next slide, please. So, further studies have shown that combining plasma exchange and IVIG do not provide greater efficacy than a single treatment. And another study explored a second course of IVIG, and it resulted not more effective than a single administration of IVIG. So the question is which treatment to choose. We said that both treatments are equally effective. However, we have to decide based on the medical history and comorbidity of the patient. And generally, I would say that IVIG are generally better tolerated and widely available. Next slide, please. What is missing in the current literature? We said the trial will focus on severe phenotypes of GBS with a disease duration shorter than 2 weeks. We don't have any data concerning mild phenotypes or patients with the disease duration longer than 2 weeks. Anyway, European guidelines back slide, thank you. Anyway, however, European guidelines suggest to treat patients with a rapid disease progression independently from the working status. The second point is the fact that we have a lack of data and low quality evidence of data comparing the dosage scheme and the administration scheme. Now let's move to the second disease, that is CIDP, so a chronic inflammatory disease. The cartoon here on the left quite well depicts the immunopathogenic network involved in the pathogenesis. However, we do not know what triggers the autoimmune response or what specific targets it affects. As previously described in the pathogenesis of GBS, also here we have the activation of both arms of the immune system leading to the generation of autoantibodies and autoreactive T cells. T cells can transmigrate across blood-brain nerve, reaching the nerve where they release chemokine and cytokines that, along with the deposition of IgG, can activate resident macrophages and complement, which are the final effector of the demyelination. Next slide, please. From a clinical point of view, typical CIDP is described as a disease in which there is a coexistence of motor and sensory symptoms. Despite this definition, there are many phenotypes characterized by different clinical features and variable treatment response. So it's a disease, very extremely heterogeneous disease. And animation, please. And if left untreated, as we said, this condition can lead to severe disability. And nowadays, the first-line treatment are corticosteroids and IVIG. Next slide, please. So what about steroids? As we can see from this slide, we have low quality data coming from the randomized clinical trial supporting the use of this drug in the chronic treatment of the CIDP. Next slide, please. What about IVIG? Well, the ICE study was published in 2008 and was the first large randomized clinical trial that proved long-term efficacy of IVIG compared to placebo. Patients were randomized to receive placebo or IVIG with a loading dose followed by a maintenance infusion of 1 gram per kilogram every 3 weeks up to 24 weeks. The primary outcome measure was the percentage of patients who had maintained an improvement from baseline to week 24. And as we can see here from the chart, the primary outcome was met. 54% of the patients that were treated with the IG were defined responders compared only to 21% in the placebo group. Also, the secondary outcome measures were met in both first and crossover period. Serious adverse events were quite similar among the two groups, while adverse events were more common in the IVIG group, being headache, pyrexia, and hypertension, the most common ones. Further clinical trials demonstrated that patients need more than 1 cycle to achieve clinical improvement, with an average between 3 to 5 cycles. Next slide, please. What about the comparison between IVIG and steroids? Well, this is the larger clinical trial that we have published in literature yet, that enrolled only 45 patients and compared the long-term effect of IVIG to intravenous corticosteroids. Patients were randomized in 2 groups, the first one receiving IVIG at 2 grams per kilogram, and the second group received intravenous methylprednisolone. The patients were treated monthly for 6 months, and the primary outcome measure was the different proportion of patients discontinuing the treatment after 6 months of trial. As you can see from the Kaplan-Meier curves on the left, the red line represents patients treated with steroid that had a high risk of discontinuation in the clinical trial. The reason for stopping the treatment were clinical worsening, clinical no improvement, and side effect. There is only one clinical trial that explored the comparison, that compare IVIG to oral corticosteroid that show no differences, and there is a lot of limitation about this trial because of the small sample size and also the short observation period. Nowadays, European guidelines do not prefer one treatment to the other due to the fact that we have a lack of data and low quality data coming from the randomized clinical trial. Next slide, please. What about subcutaneous IG? Well, in 2019, the POPS the randomized clinical trial was published that compared the efficacy of subcutaneous IG to placebo in patients that were dependent on IVIG. Patients were randomized in 3 different groups, 2 of them receiving subcutaneous IVIG at 2 different dosages, and the third group received placebo. The primary outcome measure was the proportion of patients who relapsed or withdrawn for any reason after 20 weeks of treatment. And as we can see from the Kaplan-Meier curve on the left, the placebo group had a higher risk of relapse compared to the 2 groups that were treated with subcutaneous IG. The adverse events were more common in the subcutaneous group, with the most common one being local site reaction. Only 1 serious adverse event was reported in the subcutaneous group. European guidelines strongly recommend using subcutaneous IG for the maintenance treatment in the CIDP. Next slide, please. So based on this quick overview of CIDP treatment, I would like to emerge some points of discussion. So firstly, we have discussed that both steroids and IVIG are considered first-line therapies for CIDP. However, direct comparison of their efficacy and long-term safety are still lacking. Additionally, we are all aware of the long-term side effect profile associated with the corticosteroids. Secondly, the maintenance dosage of IVIG and subcutaneous IG explored in randomized clinical trial do not always reflect the patient needs in clinical practice. Therefore, despite the lack of evidence, it is advisable to tailor the therapy to meet specific needs of the patient. Thirdly, the efficacy of IVIG is well established in typical CIDP, but what about the rare phenotypes? And lastly, we know that there is a large variability in treatment response, so we have to address this point, exploring which are the factors that might influence the treatment response to IVIG. For example, IgG pharmacokinetics, pharmacogenomics. Next slide, please. The immunomodulatory mechanisms that have been proposed are many, but the ones that are supported by scientific evidence are the following. The anti-idiotypic mechanism, so immunoglobulins can bind and neutralize pathogenic autoantibodies in CIDP, preventing immune damage to myelin and peripheral nerves. Administration of immunoglobulins can saturate the neonatal Fc receptor. We know that Fc receptor is fundamental in the IgG recycling. So administering immunoglobulins, we raise IgG to supraphysiological levels, saturating FcRn, resulting in increased catabolism and lowering the circulating antibody levels. We know that immunoglobulins can inhibit the complement at C3 levels. Then the immunoglobulins, it has been shown that can induce an upregulation of Fc gamma receptor type 2B, which is an inhibitory receptor for the activation of B cells and macrophages. And lastly, we know that immunoglobulins can inhibit co-stimulatory and additive molecules that are fundamental in perpetrating the autoimmune process. So with this slide, I ended my talk. I want to thank you for the attention.
Thank you very much for this presentation. And now we come to the next speaker, who is Helmar Lehmann. He is director of the Klinik for Neurologie und Geriatrie in Leverkusen, Germany. And he is a senior physician with a focus on neuromuscular diseases, stroke, multiple sclerosis, neurophysiology, and neurologically intensive care medicine. So the floor is yours for a presentation about the use of IgG in neuropathies.
Yeah, dear Daniela, thank you for the kind introduction. I hope I can be heard by everybody.
Yes, very well.
Okay, great. So the topic of my presentation is clinical consideration on the use of IgIG in neuropathies. And my talk will have a little bit overlap with the previous one from Dr. Falzone. But well, we're going to see how this works. So next slide, please. So these are my disclosures. Then we can move on to the next slide. So what is meant by the term chronic or neuropathies? So basically, there are a group of acute and chronic peripheral neuropathies which are considered to be autoimmune diseases. And they can be distinguished by different categories. And one category is the disease course. There are acute forms and there are chronic forms. And Dr. Falzone already mentioned two of this spectrum. This is Guillain-Barré syndrome, which is the prototype of an acute immune-mediated neuropathy. And GBS, Guillain-Barré syndrome, can be further distinguished into a demyelinating and axonal form. And then there's a rare variant called Miller-Fisher syndrome. On the other hand, there are chronic forms, and the most common one is also already mentioned by Dr. Falzone. It's called CIDP, and I will not further touch upon this. But there are also rarer chronic immune-mediated neuropathies, which can also be indications, or which can also be treated with IVIG or subcutaneous IG. So these are MMN. This acronym stands for multifocal motor neuropathy. And there's paraproteinemic neuropathy, and there's another term, it's called vasculitic neuropathy, but which is usually not treated with IVIG, therefore it's here in brackets. So what have all these neuropathies in common? You have already seen the slides before. we have pretty good clinical and experimental evidence that these are really autoimmune diseases, and that there's an aberrant immune response which is targeted against structures in the peripheral nerve. This can be either myelin or other structures. So, and this graph here now shows you a brief overview about the different treatment modalities that can be used for this group of conditions. So we have actually three mainstays. So these are steroids, PE stands for plasma exchange, and IVIG stands for intravenous immunoglobulin. And as you can see, most of these conditions, or all actually, can be treated with IVIG, whereas, for example, multifocal motor neuropathy can exclusively treated with IVIG, but not with steroids or plasma exchange. So that means that there is a careful differential diagnosis necessary before you start any treatment. There are even case reports that suggest that multifocal motor neuropathy respond well to IVIG, but can even be worsened by the use of steroids. So please, next slide. So what is Guillain-Barré syndrome? And you have already heard of this before. It's a sporadic autoimmune disease, and you can calculate that there are approximately 1 to 2 cases per 100,000 inhabitants per year. So in a country like Germany, you can estimate that there are 1,800 to 2,000 cases a year. So it's a disease which presents with a rapid ascending flaccid paralysis, which is shown in the scheme here. And please go ahead. And the patients present with different clinical symptoms like cranial nerve palsy, sensory deficits, pain, and 10% need to be treated on the intensive care unit because of respiratory insufficiency. And this is a syndrome which is typically treated with IVIG. Please go to the next slide. So the treatment of this syndrome is usually that there are two mainstays. The first is a supportive treatment, prevention of complications mainly, and treatment on the ICU and so forth. And on the other hand, there are causal immune therapies available, and this can be either treatment with IVIG or with plasmapheresis. The combination of the two treatments is not of additional value, and nowadays one has to say in most centers the syndrome is actually treated with IVIG in the dosage which is mentioned here. So I will now switch to the chronic forms, and the most frequent chronic form is CIDP, which has already been discussed. I will talk now about multifocal motor neuropathy, and this is a rare condition. So the prevalence is approximately 1 to 1 billion inhabitants. And these patients usually present with a motor dominant neuropathy, which often starts in the upper extremities. And there are some electrophysiological characteristics, and these are mainly the presence of so-called conduction blocks. It's a very characteristic phenotype. Please go back again. And the other thing is how you can diagnose this rare disorder is that many patients have IgM antibodies against so-called gangliosides. So these are the two most important diagnostic tests. And then please go ahead. And this condition, as I mentioned, is exclusively or the only available treatment that has been shown effective in RCTs is actually IVIG, intravenous immunoglobulins. You can see here a slide which is taken from the latest Cochrane review. And you see here also that the evidence for this is not very high. there are only a few studies which a low number of participants, and the reason for this is because MMN is a very rare condition. But these studies demonstrated at least short-term efficacy of IVIG treatment. There are also a couple of studies that determined the use of subcutaneous immunoglobulin in MMN. And you see here also in this table the study design and also the number of patients. And you can see here also the numbers are very low. And the outcome of these studies are kind of not entirely consistent. There are some studies that report amelioration of the clinical status. There are some patients that deteriorated under SCIG. But I think the bottom line of this slide is that the evidence for SCIG is currently quite low, just because the number of studies and the design of the studies is probably could be optimized. And the last condition I would like to mention, because it is frequently used with, or occasionally, one has to say, occasionally treated with IVIG, is paraproteinic neuropathy. And what is this kind of condition? Paraprotein, so an abnormal protein, is present in 3% of all 70 years old, so it's very frequent. And there's an association with the neuropathy. 50% of these patients have neuropathy, and which is usually a demyelinating neuropathy. Sometimes paraprotein can be secreted by an malignant underlying disease like multiple myeloma, Waldenström's disease, primary amyloidosis, and so on. So depending on the monoclonal protein, there are first a categorization possible. For example, if you have a monoclonal IgM paraprotein, then you have in 50% also antibodies against an myelin protein called MAG. And these are patients that present with a slowly progressive, predominantly sensory neuropathy. So what is the rationale to treat these patients with IVIG? So basically, there are not much treatments available for this condition. Sometimes rituximab is recommended, but the evidence for all treatments in these conditions are quite low, except for plasma exchange. There are some studies in the 1990s that have shown that plasma exchange is a valuable treatment option, but it is, of course, not a long-term treatment. Nevertheless, IVIG is often used and also sometimes recommended in treatment guidelines. Also, the evidence for this recommendation is quite low. And I don't know how the future will look like for this kind of condition, but in the advent of the development of novel monoclonal antibodies against B cells, against plasma cells, and so on, this is probably a condition that might be negligible for the use of IVIG in the future, but we will see how this will develop. And there I'll be at the end of my presentation. I thank you for your attention.
So welcome back to the second part of our workshop today. I hope you're all refreshed and ready for session 3, where we will hear additional perspectives. And the first one who will present a PPTA perspective on clinical development and clinical use of immunoglobulins is James Knowles, who is the Senior Director of Global Regulatory Policy at PPTA. So the floor is yours, please.
Thank you all to the EMA for organising this workshop. It's been really interesting so far. I'm going to just touch on some feedback from our membership on the recent releases of the EMA guidances. And for those of you who don't know, the PPTA is an industry association where we represent the three main global manufacturers in our membership of the PDMPs, the plasma-derived medical products, and also the private sector collectors of source plasma, both in Europe as well as the United States and throughout other global regions. The three member companies that I'm representing today are Grifols, Kedrion, as well as Takeda. So next slide, please. So as you know, as part of the PPTA's membership, we have and objectives is we have a strong alignment with patient groups. And I wanted to start with that. As we all know, over the last few decades, the availability of the immunoglobulins has increased, and while that we have differences in some of the manufacturing processes that the members use, differences in formulation, we've also seen changes in the routes of administration, dosing, and also bioavailability. I could go on, but really, what does that look like in terms of the landscape? Obviously, there are two main types: the intravenous as well as the subcutaneous immunoglobulin, and that's obviously broken up into either the conventional subcutaneous immunoglobulins or the facilitated immunoglobulins. I think the point of this slide is really to make sure, I think more than ever, patients have more flexibility with their care, as well as changes that the EMA make to the guidance will continue that path. So next slide, please. So again, moving to replacement therapy with immunoglobulins, again, it's been a life-saving treatment to prevent life-threatening infections with those patients that are immunocompromised with antibody deficiency. We have kind of talked with the members and wanted to provide some feedback to the EMA on some of the feedback that we received for the guidance documents. Pausing a minute to mention the efficacy being proven in primary immunodeficiency syndromes. No further studies are required to demonstrate the efficiency in the secondary immunodeficiencies, and PPTA and its members support that extrapolation. I think it's a very welcome decision in the draft guidance from PIDs through to secondary immunodeficiencies for the range of subcutaneous immunoglobulins. Next slide, please. So a little bit, as we know, the pleiotropic effects of EGs may provide advantages in treating the various inflammatory and autoimmune conditions. And I think one of the things that we talked about in the membership was, the potential, as we know, the benefits of the IGRTs are based on both immunomodulatory as well as anti-inflammatory properties. And I think the doses used in the treatments of the autoimmune and inflammatory conditions are also generally higher than those used for replacement therapy in patients with immunodeficiency diseases. Next slide, please. I wanted to move on to really the core SMPC guidance that from member feedback, it doesn't explicitly list the putative immunomodulatory mechanisms of IGs, such as CIDP. I think PPTA basically position is that it recommends the development of a standard, probably a concise and evidence-based mechanism of action statement on the immunomodulatory actions of immunoglobulins in the core SMPC. Next slide, please. I think moving over to subcutaneous use in autoimmune diseases in general, again, making reference to the statement in the clinical investigation guidance, if the efficacy in PID syndromes is established, then the extrapolation to maintenance therapy for CIDP after stabilization and going into maintenance therapy may be possible without the need to perform separate clinical trials if adequately justified. I think three main points from PPTA's perspective, feedback to the EMA. I think we welcome the consideration of the proposal to include CIDP to enable patient access to safe and efficacious subcutaneous immunoglobulins. I think also we welcome the opportunity to engage with the EMA to discuss the possibility of extending the indications to include MMN. And finally, just to highlight that the membership will provide additional feedback and supportive information for this patient population independently in the towards the comment period, which I believe is the end of May. Next slide, please. So in summary, this brief presentation, I think in general, PPTA will welcome the revision of the guidelines and the core SMPC guideline. Really, I think the vision is to enable patient access to safe and efficacious immunoglobulins. PPTA supports the use of the extrapolation of primary immunodeficiency to secondary in line with the revised guidelines. PPTA members recommend the development of a standard, concise, evidence-based mechanism of action statement on immunomodulatory actions of immunoglobulins in the core SMPC guidance. And we also welcome consideration of the proposal to include a CIDP to enable patient access to safe and efficacious subcutaneous immunoglobulins. Finally, in addition, PPTA welcomes the opportunity to engage with the EMA to discuss the possibility of extending the indications to include MMN. And I think there's been some conversations about the studies that have been presented earlier. I did want to reiterate my final slide. PPTA members will contribute independently to the ongoing public consultation period, which is due at the end of May. And thank you for your time on this presentation.
Hi, everyone. I'm Vi Katkade. I am representing Europa Bio today. However, I'm a full-time employee of CSL Behring. I head up global medical affairs for Pipeline here, and I really thank both Europa Bio as well as EMA for this excellent opportunity to provide our perspectives from the industry on this guideline. So this is, as Claudia really well set up, what we're hoping to accomplish here to get from clinical experts as well as various different other stakeholders, including industry, on extrapolating the primary immune deficiency efficacy and safety to secondary immune deficiency, CIDP, and then hepatitis A prophylaxis as well. Next slide. So as we've heard quite a bit today, that there is difference between immune replacement and immunomodulation. So primary immune deficiency, secondary immune deficiency may have a lot more similarities between them versus autoimmune diseases, which we heard about for GBS, for multifocal motor neuropathies, for CIDP. And the reason is, in immune replacement, the idea is to try and protect these patients from potential bacterial and viral infections, whereas in immunomodulation, they're not necessarily deficient in IG. However, they have autoimmune and inflammatory pathways triggered that the IG treatment is hoping to address. And as you see here, the potential mechanisms that IG uses, and Dr. Falzone did a fantastic job of outlining a lot of these different pathways where the Fc gamma receptor, the FcRn receptor, the complement pathways, as well as various anti-inflammatory and immunomodulatory effects that IG has and has been shown may be implicated in those conditions. So there's clearly a difference. What the treatments are trying to do is different between immune replacement and immunomodulation. So it behooves us to consider them separately when we're thinking about extrapolating indications from one to the other. Next slide. As far as secondary immune deficiency goes, as we all know from various different hematological cancers, and the therapies that are used to treat these cancers can lead to low IG levels, which can predispose these patients to infections and high mortality as well. And so immune IG replacement therapy has been used and is well supported by guidelines as well as clinical practice. So, so from an EMA perspective, to try and extrapolate the one trial in PID to the SID indication, so Europa Bio, we agree with that approach due to the similarities between PID and SID, and it certainly helps making sure patients have enough availability of drug in their respective countries and regions. Next slide. And this is, however, when it comes to CIDP, which is an immunomodulatory condition, as some of the things I was mentioning earlier, the mechanisms may not be similar that we see for for primary and secondary immune deficiency, and as a result, they may not be necessarily similar or same, and those differences are not fully understood yet. Dr. Maria did a fantastic job of talking about how IG is not necessarily generics. There are differences and they're not interchangeable. So, and the reason is the slight modifications that each of the different IG manufacturers have with their IV as well as subcutaneous IGs. We don't fully understand, the different pHs, sodium content, different stabilizers that are used, how that may have an impact in immunomodulation. We also learned that higher doses are required for immunomodulation versus immune replacement. And so it makes sense to individually for each of the subcutaneous IGs to ensure that the efficacy, safety, and the patient convenience is demonstrated in independent clinical trials and not extrapolated from PID. We do acknowledge there is unmet need, and additional therapies should be made available where possible. And I know that there's plenty of research going on for therapies outside of IG as well with different modalities for CIDP. Next slide. Hep A is a much simpler story. If the titers are there in the different batches available of at least 100 international units per ml, makes sense to use that for pre-exposure prophylaxis. Hopefully the need is minimal given the vaccination readily available. But however, as long as there's clear guidance on and some flexibility on what the titers would be from EMA, and the manufacturers are able to show those titers because they may vary based on where the plasma collection occurred, and may not be consistent to meet the requirements. Next slide. So in summary, for extrapolating the PID evidence from clinical trial perspective to SID, there's agreement that it makes sense and can be extrapolated. However, for chronic inflammatory demyelinating polyradiculopathies, we suggest that maybe each of the SCIGs would have to independently conduct trials given the differences. And we also heard from Dr. Falzone, it's not CIDP, is a host of different conditions which may have different phenotypes. And so therefore it really makes sense to do separate clinical trials. And Hep A agreed there's no additional clinical data required as long as the Hep A titers are meeting the requirements. So that's the end of the presentation. Thank you for your attention.
Thank you very much. Thank you, Daniel. Thank you, Chair, for the introduction. And especially thank you to Caroline and the EMA team for the organization of this first immunoglobulin clinical development workshop, and continuing this very important topic, which is showing that the agency is interested not only on topics like gene therapy or hemoglobinopathies, which were the previous workshop, but also topics which are evergreen, and the use of immunoglobulins in immunosubstitution and immunomodulation. I'm, as Daniel said, I'm heading the R&D team in LFP, and here on behalf of IFA. My conflict of interests are organically linked to my experience and to my CV. I was previously with CSO Behring for last several years, and before that with Dr. Pharma, and all three companies have immunoglobulins on the market. That's a pretty obvious conflict of interest for all of us. So a few words about the International Plasma and Fractionation Association. I have the honor of representing today on behalf of the team. It's a very special type of construct. It's an association representing various organizations engaged in fractionation of plasma into plasma-derived medicines, both from the collection, testing, and fractionation perspective. And the particularity of the IPFA is that all members are from the non-profit sector with a clear public mission and coming from all three key stakeholders in the preparation of plasma-derived products, and coming from all around the world, as you can see now here on the map represented here. When we were discussing with the teams and several IPFA and other colleagues, the keyword which came very frequently, very often in our discussion was this notion of the dynamic balance. And dynamic balance, and I tried to represent in three so pictures actually next to each other. I will try to share with you now is, first is this dynamic balance between the patient access and reward for innovation. I think we are all concerned about sustainable balance over long term, and we know that up until now, actually not recently, but up until now, up until today, this balance was very regularly perturbated by regular issues with the supply and challenges with the plasma collection, like for example for COVID years. And then I realized that maybe this image, prepared in a PowerPoint is maybe too simple to represent this idea of the dynamic balance. And I went for a picture, which is here representing a more of a physiotherapy session when a patient probably is trying to keep his dynamic balance when being destabilized by the external environment, or in this case, by his physiotherapists. And even that appeared to be too simple for me. And then I did what usually people do when they don't know what to do, asking ChatGPT. And the prompt was actually, in this case, was to represent the dynamic balance and to visualize the dynamic balance between the innovation and patient access to treatment in the field of immunoglobulins. You can easily recognize this picture is coming from DALL-E or from ChatGPT's let's say visual little brother by typos, actually, which all of artificial intelligence systems are making when drawing images. But it's also clearly visualizing for me the fact that actually if one of sides of the balance is going down, you can see here the patient represented on a rolling chair. Actually, it's not that the patient access is going up is not necessarily the most stable situation, because it can roll down easily and all of the balance will be perturbated under the impact of external factors, as we had during difficult situations like COVID years. And the next part of less visual parts of my presentation will be mostly based on the idea of commenting on the main topics of the workshop today, with a very clear understanding that we are in a very special situation around immunoglobulins with the plasma-derived products, as immunoglobulins are actually defining the fractionation volumes for all of plasma-derived products. So they are like the main product defining the investments in the fractionation, both from the collection and the fractionation perspective. However, in a moment of need, there are also regularly prioritization exercises. And here, I think most of participants are familiar with the topic here, can easily recognize two of examples of prioritization exercises which were put in place by big national authorities, in one case in France, and another case in UK NHS, when the supply is challenged, how to prioritize the patient access to treatment. And what was interesting for me in these exercises and preparing to talk about the clinical development is that we see that those prioritization exercises are based on different elements like therapeutic alternatives available. That's I think an obvious element, the quality of evidence, and the how robust is that evidence and how good is considered by the agencies, but also other considerations. But none of considerations is taking the fact that actually patients need also clinical trials and long-term drug developments. And in a moment of need, clinical trials may not necessarily be prioritized, or I would even be more direct and say will certainly not be prioritized, whether by manufacturers or by authorities saying that, we should avoid treating patients with improved indications and then providing the product to clinical trial conduct. So that's one of typical challenges we are facing in the clinical developments. So in this dynamic balance, we do have a number of challenges that I'm usually saying that all challenges also representing also an opportunity. And typically, some of them may indeed represent an opportunity where we can work together in solving them. Studies in immunoglobulin clinical developments are very costly. And this is related. All studies are costly, but this is also particularly true for immunoglobulin studies related to the cost of investigational medicinal product, which is actually the plasma drug product. So the cost of goods in case of immunoglobulins is really very high. And then in a situation of a very regular, very repetitive supply challenges. We are talking about a rare disease and over-solicited patient population, at least in countries where you usually do clinical studies. And obviously, even for very rare indication, there is an existing approved, whether it's an in-label or in guideline or guideline recommended or national authority or hospital or any other type of authority recommended use. So patients' choice in the case of entering in a clinical trial, it's not between no treatment or clinical trial, it's between approved treatment, whether it's a label or guideline approved, or a treatment in a clinical trial setting, which is much more cumbersome for a patient and represents much more complexity. The additional level of innovation on a market access level and additional data are not necessarily recognized as a differentiation point for price differentiation. We do know that in most of countries, or in all places, the prices of immunoglobulins are flat, independent from indication. It's a very challenging and evolving landscape, especially, and I think Peter Asdal did a great job on presenting the evolving landscape of secondary immunodeficiencies, especially related to arrival of new type of treatments. One of opportunities, and I really truly believe that this is a really great opportunity. Not many products have this existence of core SMPC, which is positioning intravenous and subcutaneous immunoglobulins in a very unique situation. Without being biosimilars or being interchangeable, there is some core link between different products in the form of a core SMPC, and it's actually a pretty unique situation in the world of clinical development. And then, of course, one of the biggest challenges, we all have this plasma collection, geographical imbalance, and immunoglobulin supply and demand evolution. And clearly, that's why also I'm fully acknowledge the participation of the Hematology Working Party also in discussions around SOHO legislation and working on other aspects, not only the clinical development, but also everything which is upstream of the immunoglobulins, which is the plasma collection. So how we can overcome challenges together, just a couple of initial ideas here. As stakeholders in the field of immunoglobulins will be certainly interested in is more of a predictability and clarity and transparency about the core SMPC process and its evolution. So when potentially new type of details may be updated and entering into the core SMPC. The collaborative approach to clinical development, including anticipation of potential iatrogenic side effects of other drugs, may be another interesting piece to explore, because actually we are seeing that the most evolutive areas, notably on secondary immunodeficiency, and the example was given previously that actually there are recommendations in a label of CAR-Ts or other products which actually are not necessarily aligned with the companies working on plasma fractionation and development of plasma-derived products and data produced by those companies, especially because those data are actually fairly lacking today. And most importantly, and this is one of elements which I would like to highlight, especially as a positive element in the evolution since many years of the position of the European Medicines Agency, is the innovative approach to evidence generation and consideration of all of available evidence, which is especially true when we are talking about a product which products actually, which are regularly in a situation of a challenge of supply. And there is always a choice to be made between clinical trial and the regular use for patients who are in need. And those type of additional type of complementary type of evidence may be especially useful not only for indication, but also providing additional clinical use guidance, such as the dose or starting, stopping rules, or all of the other elements which are on top of indication in our labels. And when we're building this slide, I realized actually that most of it is already coming in the European Medicines Agency Clinical Evidence 2030 position, and this was this great paper shared days ago. And I see that all of those ideas are very similar and very, very close to what we are observing in the Clinical Evidence 2030 EMA strategy. So to finalize, to continue and finalize. So as I said, the very much in line with the approach of the agency. Also especially on the Principle 4 and Principle 5, and with the full spectrum of data to be used and the generation of clinical evidence planned much earlier. And here we had some examples in the past, not in the world of immunoglobulins, but there's one or two examples where the company working on medicinal products which may induce serious iatrogenic side effects like immunodeficiency in the case of CAR-Ts or other treatments we were discussing about, also being interested and working on developing, let's say, potential solutions for that. And the example we have now over last years, actually, this was the development of an oral anticoagulant and its antidote more or less simultaneously by one of companies working in the field of oral anticoagulation. So this collaborative approach and much earlier approach of planning can be one of easy solutions. I would like to finish this presentation by what is on top of this very nice scheme coming out from the clinical evidence paper by EMA, which is showing the patient voice. It's where things are starting. It's really on top of everything and listening to what patients' needs are and how we can improve and increase the patient access to treatment, but not only just one type of treatment, but several options of treatment, which would allow this true patient-physician dialogue and shared decision-making in the field of the use of intravenous and subcutaneous immunoglobulins for a number of different pathologies. With this, thank you very much. And for any feedback, please don't hesitate to reach out and let's discuss this in the panel.
Thank you very much for this presentation, Karen. And indeed, the workshop is thought at least to address one of the challenges you mentioned on your slide, and to really have this multi-stakeholder discussion on the guideline of the core SMPC. But of course, we then will have time for that during the panel discussion also. Our next speaker is Anja Schiel, and Anja is a special advisor and statistician and methodologist, both involved in regulatory and HTA projects at the Norwegian Medical Products Agency. She was the former chair of EMA's Scientific Advice Working Party and also chair of the previous Biostats Working Party. Now she's a member of both of the working parties. And today she will talk about HTA perspectives. Anja, please.
Thanks. And we can already go to the next slide, because I think after the previous speakers, you have probably learned everything there is at the moment about the treatment and the science behind it. But anything that is approved normally also needs to be paid by someone. And to bring you the basics about the role of the HTA, I will simply only focus on the PID and the SID at a very high level. Can we have the next slide? Yep, thank you. So I think a little bit in disagreement with at least some of the previous speakers from a scientific, but also definitely from an HTA and reimbursement perspective, we need to acknowledge that there are obvious differences between PID and SID. PIDs are, as you heard, congenital, and they represent a very heterogeneous group of manifestations, which is usually something that we find difficult at the HTA level when we have to assess the technology for reimbursement, because this is contextualized, and I'll explain it a little bit better in a minute. The fact is that the PIDs represent very early in life, and they are chronic in nature. Not all patients will have the need for active treatment per se, but prevention is currently not possible. And there are curative options like allo stem cell transplantation or potentially gene therapies in the future. But this is very different to the secondary situation, because the SIDs are acquired either through a different other condition, or they can be simply the consequence of a treatment such as a chemotherapy. And this complicates matters when HTA assessments are considering SIDs, because they could look at them as part of the oncology indication, or they can look at them as a separate entity. The underlying risk factors for the development of SIDs are also rather unclear, and hence the prediction of SIDs is difficult. And what we have seen and what is reported is that treating just in case seems to be a major factor in driving the costs in some areas. Next slide, please. The challenges are obviously that the heterogeneity in the PIDs, but because this is a childhood situation, we are usually very willing to overcome these problems and be as productive in our approach as possible. But again, treating when needed instead of prevention is really very important. And we heard already from previous speakers that the treatment algorithms have to really be tailored to the patient and also fit to the healthcare system in which they are applied. One of the problems we are also seeing, and you heard it before from pretty much anybody, is that there has been little research done since the 50s when these treatments were established. So it's kind of well-established use that can pose a problem in terms of reimbursement. The most important aspect that has an impact on cost effectiveness in PIDs is, as a matter of fact, the newborn screening, because that has been routinely shown or consistently shown that this has a huge impact on cost effectiveness. But for SIDs, this looks a bit different. There's a red thread through all the presentations that have been telling us that there's little robust evidence on the effectiveness of replacement therapy across the board. So it's in some situations, maybe we have a study, small, very focused, but in general, it's very difficult. It has been reported that the number needed to treat is relatively high. So to prevent just one serious infection, which is the ones that HTAs would probably be most interested in, that lead to hospitalization, you need to treat an awful lot of people, which is very expensive. And then there are newer antibiotic alternatives that have evolved over the last decades. But one aspect that is really interesting is that there are huge regional differences reported in the preference for initiating replacement therapy versus preventive antibiotics. And this obviously then can have a huge impact on the individual national assessment. Next slide, please. When you have been all talking about we need more clinical trials, and you're all talking about this left-hand side of this picture here. So we can optimize trial designs for regulatory purposes and approval, but that comes with a caveat, because when reimbursement decisions have to be made, then we are not longer talking about absolute effectiveness, which is the one that is assessed in the benefit risk, but rather relative effectiveness, for which we normally need a comparator. This is a figure on top, the formula for the ICER, the incremental cost effectiveness ratio. We model, some of us at least, model our way forward into a counterfactual future in which one treatment exists instead of another. But all of this requires normally very robust data. And as we just said, we don't have this robust data, neither on PID or SID. And all of the HTA and reimbursement happens on the middle and the right-hand side of this figure. And since these assessments really need reasonably good evidence, we have a gap already in the middle, but the appraisal on the right-hand side, so the actual decision, is far more complex. And here, all the other elements of healthcare systems come into the picture. Distance between treatment centers. Is it really better to give somebody a subcutaneous when that requires allows less oversight, brings a higher risk for missing doses or less effective treatment? These kind of things need to be considered and are part of this tailored approach. Since January this year, the first group of products, oncology and ATMPs, have to undergo mandatory joint HTA assessment at the EU level. That means from somewhere between the left-hand green arrow to this big fancy picture in the middle, there happens something at the European level. It's called the Joint Clinical Assessment, and it means that at the same time as a submission is given to EMA for the approval, a similar submission process starts, and it will require the developers to bring additional evidence to support the assessment of the relative effectiveness. So the thing on top, against a existing treatment or an existing comparator, another active product. My picture is on cost-utility analysis, but there are other ways to do this. All together, these are supposed to pave the way for decision makers to do the exercise, which is the appraisal on the right-hand side. The generalization of your results and the available evidence in the context of a specific healthcare system. And this is a purely national process. And hence, every national healthcare system with its peculiarities will result in a so-called PICO, which explains what kind of evidence your product will have to bring to the table at the time point of the submission to the HDAR coordination group. Blood products are not explicitly mentioned anywhere in the upscaling, but by 2030, all products that apply for MAA must also go through this HDAR process. Next slide. The big problem we are facing, I think, as healthcare systems is simply what you see on the left-hand side. There's an enormous increase in use of intravenous IgG. It started between the 80s up to the 2000s, and then increased even further. It is unclear where this increase is actually coming from. Next slide, please. Because when you look at the guidelines, then there is no indication that any of the guidelines would potentially suggest more use in either the PIDs or, next slide, the SIDs. So maybe even one would see that some of the guidelines discourage certain use of IVIG necessarily. So this raises a concern that there is some substantial off-label use, and it has been reported to be up to 50% of all use in some regions, which is accompanied by an ever-increasing budget consequence. The costs of these kind of treatments have been reported to be between 20 to 30,000 per patient per year, I think. And we also have the problem that it makes a huge bunch of the expenditures in hospitals and in some countries. So on the next slide, I'll summarize these problems. I would say, while for prime PID, the HTA assess impact on reduction of frequency in infections, most likely as the main outcome. There's no expectation of any other impact it would have. The heterogeneity is a problem, but in general, we are willing to generalize and extrapolate, but not in the sense that we discussed with you before, to other indications, even though this will cause some uncertainty. The one thing that has been consistently shown is that subcutaneous injections have a huge potential to be cost effective when appropriately used and tailored to the patient. But it remains a case-to-case basis. Some countries might not benefit as much. SIDs, on the other side, the poor documentation is and remains a huge problem. Lots of the evidence is outdated. As said, up to 50% of the report is off-label, which can then obviously not be assessed in any proper way. And there's very little to no existing clinical evidence that would actually allow the treatment. And the annual costs, as said, 20 to 30,000 per patient. Up to 70% of hospital drugs expenditures in Belgium have been reported. And it accounts for 50% of the Australian total budget for blood products. The consequence is that in a systematic review just recently published, the statement was, as of 2024, the full cost of IG treatment and cost effectiveness in hematological malignancies remains unknown. And this is never a good thing. Next slide, please. Because we also have seen that there is very little literature on the cost effectiveness itself, because it's not only about the clinical trials that go into the assessment, but also about the assessment itself. So also from last year, I think there is this peer review that looked into all the cost effectiveness studies that have been reported. They are all small, too specific, and they only found two that were really relevant. The right-hand one is a more recent one, which is the one that is always referred to when it goes about the cost effectiveness of the subcutaneous injections, and the left one is the only other one, and you can see it's from 1989. It's completely outdated, and it really doesn't help and doesn't represent nowadays situation anymore. So last slide then. Decisions in PID are supported at least by some data. The established use is something that probably helps to some extent, because it tends to end in a cost minimization approach, meaning any new product just can't be more expensive than existing ones, but we can use them. Early treatment initiation is crucial because this clearly improves cost effectiveness. So newborn screening is really essential. For the SIDs, the decisions will always be case by case. The poor evidence is resulting in high decision uncertainty, and the moment that these products are assessed, budget impacts will also play a role. The substantial off-label use is a problem, and it is unclear to me whether more indications in the SMPC are necessarily going to help here, because then you really need robust evidence for each of these indications. The budget consequences are definitely gaining attention, and they must be addressed. We hear that hospitals, from earlier speakers, are very conscious about the costs these products accrue, and that you really need to make good decisions whether it is just for because it's there, or whether you really need to treat the patients. So the awareness among physicians on the costs and the market forces are also needed in this situation, in which we experience an increasing supply challenge, and at the same time more and more users which have no support by clinical evidence. Thank you.
Thank you very much, Anja, for this interesting presentation. And last but not least, I would like to introduce you to Klaus Grudwig, who works in the supply and availability of medicines and devices workstream at EMA as the Medicines and Medical Devices Shortages Specialist. And he will talk about monitoring of supply for immunoglobulins.
Thank you very much, Daniela, and good afternoon. So it's a great pleasure to present here in this forum. We want to present not only on the monitoring of supply for immunoglobulins, but we really want to give you an overview about shortage management activities in the EU. So the next slides will provide an overview about different activities, and this is just my disclaimer that there is nothing to declare. So the next slide is basically focusing really on three main pillars of shortage management activities in the EU. So the first one is really improving the availability of medicines authorized in the EU is a key priority for the European Medicines Regulatory Network. Regulatory authorities are increasingly working together to prevent shortages and to limit their impact whenever they occur. And the third point refers to the HMA-EMA task force on the availability of authorized medicines. And here I would like to give a small update because the policy group no longer exists since the end of 2024, but functions and relevant activities have been transferred to the MSSG, so the Executive Steering Group of Safety and Shortages of Medicines, and the SPOC Working Party, and the work will continue there. So I mentioned already now kind of MSSG and SPOC Working Party, and the next slide will introduce actually the function of these two groups. So, but before going really into detail here, I wanted to mention that EMA's role in crisis preparedness and management is actually reflected in the Regulation 2022/123, which really formalizes structures and processes that have been established during the pandemic. So the Regulation 2022/123 provides a framework for activities to monitor and mitigate potential and actual shortages of medicines, sets process and tools for shortage reporting, coordinates responses of EU countries to shortages of critical medicines during crisis, and for monitoring of events which might lead to a crisis situation. And here is the link to the establishment of the MSSG, which is supported by the SPOC Working Party and the network of contact points from pharmaceutical companies, which is called the Marketing Authorization Icebox. And then also foreseen in the regulation is the development of the European Shortages Monitoring Platform, ESMP. So the next slide provides a little bit more graphical overview about the interplay between these different structures in terms of the EU-level coordination. So on the left-hand side, I already made a reference to the activities of the task force, and that they have been transferred basically to the two structures in the middle and on the right-hand side, so the SPOC Working Party and the MSSG. So what are these four groups? So let's start with the MSSG. So it's really an executive group. It operates in crisis and preparedness activities. So that refers actually in terms of crisis to public health emergencies, but also major events. The executive group's function is to provide opinions on major events, defines and publish the list of critical medicines, monitoring of shortages, supply and demand during public health emergencies and major events, and provides recommendations to member states, industry, and the European Commission. So in the middle side, basically in the center, we have the work of the SPOC Working Party, which is an operational group, operates in normal circumstances, crisis and preparedness activities, and is engaged really in monitoring of shortages and monitoring of demand and stock of critical medicines during major events or public health emergencies. So next slide gives a little bit of a further overview about the prevention of medicines shortages. And here we would really like to make a reference to one central recommendation. So on the left-hand side, there's the recommendation to strengthen supply chains of critical medicinal products. And these have been published in the last year. It refers to increasing of manufacturing capacity, to monitoring forecast of supply and demand of medicines, available stock in the entire supply chain, and closely linked actually to these recommendations is the Union list of critical medicines on the right-hand side. And just to stop here for a small moment, basically, and give you a little bit more detail here, because as you are very well aware, immunoglobulins have been included actually in the Union list of critical medicines. So what is this list? So the Union list of critical medicines identifies medicines that are critical for health system across the EU and EEA countries, and for which continuity of supply should always be guaranteed for European patients. And just to make a further reference here, the inclusion in the list does not mean that the medicines are likely to experience a shortage in the near future. It really reflects basically the need of the availability of these medicines. So the next slide gives just a little bit more overview about mitigation, the impact of medicines shortages, and I will be very brief here. So for the left-hand side, there is the reference to the international cooperation, and we interact, for example, with international regulators, for example, with the FDA, Health Canada, or TGA in Australia, through the Global Regulatory Working Group on Drug Shortages, which meets on a quarterly basis, and facilitates basically international cooperation on drug shortage reporting, signal detection, and signal assessment. Of course, there is also bilateral exchanges with international regulators. So then we're in the center of this slide, we want to make a reference to the MSSG solidarity mechanism. So this is the voluntary solidarity mechanism, which is used as a last resort to temporarily alleviate critical shortages in a member state. And here, basically, really a number of conditions must be met. For example, that insufficient quantities to treat critical indications, and also, of course, the urgency in terms of the urgency to react. The MSSG has also published an MSSG toolkit, and this toolkit defines further activities that can be pursued. For example, granting of regulatory flexibilities, if appropriate, communication activities. And for example, communication activities, you may remember that also a shortage catalog entry for immunoglobulins has been published in June last year. So with this, I want to go to the next slide. And the next slide is already the conclusion and next steps. And here we wanted to start with further detailing that the MSSG, supported by the accompanying single point of contact working parties, continues to ensure a robust response to medicine supply issues under preparedness activities or during major events or public health emergencies. And it coordinates urgent actions within the European Union to manage medicine supply issues. So there is a clear shift from a reactive management approach to a proactive prevention approach to ensure the supply of medicines. And also the new EU pharmaceutical legislation proposal, which is currently under negotiation, together with the initiatives foreseen in the European Commission's communication on tackling medicines shortages in the EU, including the CMA, will further reinforce the security of supply for critical medicines and the prevention of shortages. And the last point we wanted to mention here is that the EMA continues the monitoring of shortages of immunoglobulins very closely through the SPOC Working Party. And currently the MSSG is developing a set of specific recommendations for ROD immunoglobulins and TD immunoglobulins. Thank you very much.
Thank you very much, Klaus. We can now move to the panel discussion, where we invite all the speakers. And Caroline will also co-chair this discussion together with me. And well, the aim of our panel discussion is that we would like various questions and aspects from a regulatory and clinical perspective, but also to get to some of the questions are really for everyone here, where we're interested in all the perspectives. And we prepared some questions to guide the discussion. And I suggest that we start with the first one. With regards to the established indications according to the EMA guideline and the CORES MPC, do you think that these indications need to be further amended? And are there any gaps or possibility to further optimize the treatments? And are there new indications that may be considered established indications? And I would like to ask the clinicians maybe to give their view and responses to the questions.
And I think, Daniela, what is really important for us is really to look at treatment optimization, because this is something which is very important at the moment for EMA. So we look into various diseases, and it's really important that we look on how we can further optimize treatment. And as we mentioned before, we cannot, it's not within our remit to look at treatment guidelines, but still we provide recommendation as part of guidelines from the EMA side. I see that there is a raised hand, so maybe we can start with Cristina Santoro, perhaps, and then we'll go to the
Hi. Yes, hi. Nice to meet you. I'm a hematologist, and I'm working in Rome in the University Hospital Policlinico Umberto I Sapienza. I wanted just to ask you about another indications. I think you've never mentioned it here because it's not registered, that it's for the acquired von Willebrand syndrome. So this disease is a rare acquired coagulopathy, which can be very important for the patients affected, and especially if there is a concomitant correlation with plasmacellular dyscrasia, like monoclonal gammopathy. And there is a lot of literature about the use of immunoglobulins in this rare disease. So I don't know if this is the right consensus where to talk about it, but because you were also talking about new indications, of course it is impossible to have like a study in this kind of patients because they are so rare that is impossible. But I think that there should be something by the regulatory organs to let the use of immunoglobulins in this setting easier, because it's the only quite the only efficacious therapy.
Well, if I can comment from a regulatory perspective here, so on the one hand, our clinical guidelines define the requirements that are needed to obtain marketing authorization, and it's up to applicants to apply for specific indications, and we then will assess the data that are submitted. For the indications that we have in our guideline and the CORIS MPC, it's very clear what data are expected. But of course, we also have in the guideline a statement that for any additional indications, applicants need to submit data accordingly. What kind of data, of course, is also then dependent on the indications. If it's quite unclear, then there's also the possibility to ask for scientific advice, for example, to get scientific advice on the clinical development program. But I think here now we cannot comment if this is an acceptable indication or not, because we assess the data that are submitted and then we do the benefit risk assessment based on these data.
Okay, thanks.
And this would be considered at present as off-label use. So that's also like something that we would not see at EMA. Yeah.
Okay, perfect. Thank you.
Okay, I think there is several questions. So Francesco Rodiero first.
Thank you, Caroline and Daniela, for this interesting meeting. I just would like to support the previous intervention because this acquired von Willebrand syndrome is rare, but it does occur and maybe it is ameliorating and even resolving by using intravenous IG. But I want to go back to ITP for a moment. I'm a clinical hematologist. I'm involved in writing current guidelines in Europe and also in a consensus document on terminology, as Caroline knows very well. Dr. Svoginga did a very short and nice presentation. I want to be sure that there are some points recognized here. The treatment of ITP does not fit with replacement concept and also does not fit completely with immune modulation because probably the mechanism is very simple. IgG given to the patient saturate Fc receptor gamma so that the platelet cannot be further opsonized by the autoantibody and escape the macrophagic destruction. But apart from this, I would like to stress the real indication of ITP in ITP of IgG that were very shortly or not mentioned. One could be preparation for surgery, particularly in an emergency situation, or where the patient is anticoagulated and needs a prompt increase of platelet count well above the 30 or 50,000 per microliter. Another situation are emergency situation where, for example, there is massive bleeding, gastrointestinal bleeding, hematuria, or the fear of intracerebral bleeding. And the last, but not the least, and was not mentioned, is that we have not approved the drugs for treatment of ITP during pregnancy. The only treatment is corticosteroids, if it is possible, but in some cases it doesn't work or reveal to be toxic. So that regular administration of intravenous IG is required for this patient or also for preparation to parturition. So we, as treaters of ITP, would like to be reassured that all these possibilities are maintained off-label or, let's say, if you require other information, but I want to be sure that these points are kept in mind by the EMA. Thank you very much.
Yeah, so maybe I start. So we cannot say, these indications would be agreed by EMA because, as Daniela mentioned, for us, we look at the applicants or the MH data that are submitted to us, and then we grant indication with the data that have been reviewed. So if it's not part of the product information for the corresponding product, we cannot say, for example, this is acceptable in clinical practice to give immunoglobulin in this particular indication. So this would be perhaps looked at treatment guidelines, but again, this would be considered as off-label use. So in terms of liability, it's also the clinician liability to give these products, and then the companies need to also look at off-label use. So that's actually the case at present because companies have a legal requirement to provide off-label use data as part of their periodic safety update report assessment, and we usually look at that in this regard, but it's impossible for EMA to acknowledge indications which are not on the label, obviously.
Yeah, that's true. I would not insist. It's important also with regard to the previous intervention that there are not set priorities in the distribution of these agents, excluding those that are off-label. That's the point. Of course, it's up to the guidelines to provide the good suggestions for use of these drugs.
Yeah, and the companies to do the clinical trials as much as possible. Yes, but thank you, because then it's also giving some direction on the potential use of immunoglobulins, especially for the manufacturers. I see that Dot has a question or raise a hand. Dorothy?
I just had I think a simple question, but in discussing extrapolating the primary immune deficiency indication to secondary immune deficiencies in various types of secondary immune deficiency, I wonder the degree to which there are differences in the array of infections that primary immune deficiency patients have versus the secondary immune deficiency. So, for example, will IVIG or sub-Q IG actually cover enough of the infections. In other words, what are the common infections in these secondary immune deficiencies? And it would be nice, just research-wise, to look at the antibody levels to those infections. I'm not suggesting anything drastic, but there may be differences. That's all. Thank you.
Yeah, that's a very good comment, indeed. And that's also the nice thing about this workshop is that we look at different indications. So it's nice to see commonalities or differences between the use in various indications. So yes, I think that's a very good question. Maybe Peter Asdal, do you want to address that, or maybe you have another comment?
No, that was just a comment to that. I totally agree. I think it's too early or just a fault to extrapolate too much. And I mean, very simply, you can look at the two different populations. I mean, primary immunodeficiencies, they're kids, and they don't have response to the type of infections that you will have during your childhood, which is different when you're 60 and you receive a CAR T cell therapy. You have your immune response already, and to some degree a diverse pool of IgG circulating, and also I have to say also IgM and IgA and what else you can think of. So I think it's a fault to just extrapolate. Of course, we can look at the different areas of research, but you can't just extrapolate, as I think some have also walked through their talks about. Thank you.
Thank you, Peter. Yes, I see Maria. You want to comment?
Yeah, no, just thank you. I fully agree with Peter's observation. Just to clarify that, people with primary immune deficiencies are not only children, but even young adults. More and more young adults with, thanks to the improving in genetic testing and diagnosis, and in late onset primary immune deficiencies that are in such a way not so devastating in childhood, but presenting with organ damage since adolescent or since the young adult age. But at least even in cases in which we have still not a genetic diagnosis, we can take advantage of biochemical biomarkers as immunophenotype, and we just need a decreased level of IgG and an impaired B-cell immunophenotyping to declare that the patient is in need is suspected for a genetic PID. So we can claim for immunoglobulins. Just this. Thank you.
Yes, and maybe going to the CNS indications, are there any comments to Yuri or Almar? And I can see that Dot also had questions about Kawasaki disease and dermatomyositis. So I think that's applicable, I think, to so Kawasaki, I think it's IVIG and not for dermatomyositis. But I don't know, maybe Yuri or Almar, do you want to comment for the CNS indications?
I think that, as you said, maybe concerning the peripheral nervous system indication, we should focus on optimizing. I mean, we currently use the immunoglobulins. However, we don't know what is the optimal dose, the administration scheme that we should propose to our patient. We tailor the therapy based on the patient need, and many times this dosage is not similar to the ones that were proposed in the clinical trial. So I think that that's the main limitation that we have in clinical practice from the neurological point of view. Concerning other indication, we discussed about the motor, Professor Lehmann discussed about the MMN, so the multifocal motor neuropathy. In that patient, we had IVIG, but we don't have many indications concerning the subcutaneous IG, so we should also work in that direction. While concerning Guillain-Barré syndrome, I would say that basically that's a devastating disease. So we have to use the immunoglobulins or plasmapheresis as soon as possible in the patient journey. So I would say that we have to use the standard of care that is now, I think, optimized. So that's my general comment about dermatomyositis. I mean, it's not my main focus anyway. I think that also in that condition, immunoglobulins may be helpful to treat patients, so more data would be helpful in this clinical use as well.
Okay. And that's already leading to the second point about dosing recommendations. I think there are a lot of comments with this regard that there is still maybe some gaps in terms of posology recommendation and the appropriate dose to recommend. But again, I think it will be difficult to have specific clinical trials for that. So do you have any specific recommendations, or maybe can we use actually the data from coming from clinical practice or real world data to be able to better understand what kind of dosing recommendation should be given? And yes, if you have any insight, or and we have acknowledged already that this is an area where there is a possibility to further optimize treatment for immunoglobulins. Yeah, so who would like to start? Maybe Maria?
Yes, sorry, I lost your last words. So if you can say it again.
Yeah, I was wondering if you have any, insight into how we can further improve the dosing recommendation or posology. I think this is an area where we have seen that there could be some optimization, but again, conducting clinical trials for that might be difficult. So maybe learning from clinical practice could be an option. Do you think that this would be envisaged? And of course, we have a new pharma legislation where actually this could come, we could have data coming from the clinicians directly or a clinical practice, and especially if it's to optimize treatment. So would you have any comment on that? Thank you.
Yes, thank you. Very, very crucial point. We have already mature data to reason about the different formulation of immunoglobulins, even subcut and facilitated subcut with hyaluronidase, because they are very popular. The advantage is very clear. And in my institution, for example, I really put the differentiation, of the product, and I really love to test diverse products in the same pediatric population. I think we all need. We really need all this product in order to customize the patient treatment. We have data. I personally speak about a very young pediatric population up to adolescents and young adults. Again, so in case you have a central venous catheter, you for sure try to optimize the EVIG, but we often drive the patient to subcut, and even the hyaluronidase formulation is very appreciated by FEMI. So I think we have just to collect data, even retrospective data, and we can analyze data of safety and efficacy in terms of IgG levels and rate of severe infections according to age, and we are to me ready to to open the choice to even to the last formulation of subcut.
Thank you, Maria. I see Anya as a raised hand, so maybe you want to.
Yeah, because I think that in particular in an area where there is a lot of experimental use and off-label use, but also where there are non-approved products, because I think there are still hospitals that produce IgG on their own and use it within house. The collection of structured data would be extremely relevant. And it's one of these areas where it should be really easy, as a matter of fact, because we do not necessarily have to differentiate between different products. We just have to look at the totality of use and start trying to understand whether there is a picture or not. And then in this field, maybe if we could generate enough real-world evidence out of the available real-world data, then we could finally discuss whether an extension of an indication is possible. But we are in this constant conundrum of saying, well, the clinical trials are too expensive, but the products are also expensive, and the products are used all the time, everywhere. So yes, obviously it would be a good idea. And maybe it is also about, for example, suggesting something to the Darwin EU group to look into and do a feasibility exercise in finding out what is actually collected, because it doesn't have to be a real full-blown study right away. It is more important to understand what kind of information is actually out there, and could we potentially improve that in the future, with the explicit aim of saying, well, this time we might actually want to accept just real-world evidence and no extra clinical study.
Yeah, thank you, Anya. I see that Karen has his raised hand. Karen.
Thank you, Caroline. And I would like just to very strongly support, Anya, your intervention there. And I think this was also some elements of what I tried to bring across my presentation, that, you know, as I mentioned, I was back and forth in immunoglobulins fins in 3 different companies over the last 15 years. And every time I was coming back to immunoglobulins, I was having a feeling of a deja vu, that we discussed this, but actually positions were too far away. Everyone wants to randomized clinical trials. We don't have them. There is a shortage supply. We don't do anything. So asking the same question again and again and expecting different answer is probably not the wisest as they may have. And then maybe this time trying the different part on working all together as stakeholders and using these advantages we have actually, which is actually pretty exceptional, very positive situation that we do have a core SMPC, not many products have. I think maybe another couple of products. And actually they can learn also the field of fibrinogen products, for example, can learn from the core SMPC approach in immunoglobulins, IVIG, in subcutaneous, and maybe even in the future alpha-1 deficiency also can learn from the approach of core SMPC. And then aligning together on what is the minimum necessary evidence, where to start, and what this can bring to whether it's the public or private stakeholders of plasma fractionation, especially to work in these rare, very rare indications we are talking about. So we would strongly support this approach, and I think this will be absolutely make sense, both from regulatory and market access perspective.
Thank you, Karen. And I think we have seen during COVID that you actually teamed up in terms of manufacturers to do a clinical trials to use hyperimmunoglobulins to treat COVID-19. So it's actually feasible that manufacturers can team up and do a clinical trial together. So maybe this is perhaps a way forward, but at least, yes, it's easier if you have more people joining in to get, participants. And also, I think it's important that we get, prospective data as well for future indication, so that are collected in a standardized way. I'm sure that Tanya would agree with that. And then I think we can look at safety concerns. So that's also something that is really important for us to be aware of. And of course, there might be differences, and there are differences between the route of administration, so between intravenous and subcutaneous. But are there any specific concerns that maybe we don't see in regulators coming from the clinical practice that you would like to highlight to us. So again, I think we can, I think Peter, I don't know, you had your raised hand. I don't know if it was for that, but would you like to comment? And of course, maybe for oncology indications, as you mentioned before, if a patient is already taking his fifth treatment, of course, there is another context to the patient. So depending on the treatment, the intended target indication, obviously. But yeah. Do you have any comments? Maybe we start with Peter.
Yeah, thank you. Well, my raised hands was actually on the prior topic, but I think we agree very much on that. But I'll just like to say that you can collect a number of retrospective data on this and maybe get some fine analysis, but what is really needed is trial data, and I think we agree on that. It's just underscore that a lot. Regarding the safety issues, so being a clinician using this drug regularly, I don't think there are much safety issues, at least in the secondary immune deficiency setting. There is one thing that we discussed in Denmark for some time, which is we have very different practices on the startup of the drug. So do you start with, for example, 10 grams and then after a week or two go to 20 or 30 grams, or do you go right away for the full dose? There are very, very different approaches to this, and I'm not sure what's in the SPC for that, but I can just see for HyQvia, which we use a lot at the moment, they recommend starting with some lower dose, which is not specified more than that. And the reason behind that is actually a little bit difficult to see, but I believe it's allergic reactions that people are worried about. I can just shortly say that we give half dose, typically 10 grams. 2 weeks later, we give the full dose, typically 30 grams.
Thank you, Peter. I think, Maria, you wanted to comment?
Yes, thank you. Yeah, I agree. It's the way the ramp up dosing for HyQvia is just scheduled. I am really in favor again of prospective studies, also for indication of subcut IgG for acute illness. So in my view, it's so clear the effect in terms of sparing of systemic reaction for subcut IgG that I would really propose to conduct prospective studies on the use of subcut even for the treatment of acute infections, so when a patient is hospitalized. So I think this could be a way to really have the possibility to monitor this patient and to pave the way for cheaper products with less occurrence of systemic reaction, in particular that sometimes counterbalance, in for EVAG, the benefit for the treatment of the infection in itself, and this could be a way to even approve the indication of subcut even for acute infections and illnesses.
Mm-hmm. I see a comment in the chat. So from Daniela. So Daniela, I don't know if you want to. I can read your comments. So regarding the prevalence of CIDP, 5 to 10 to 100,000 people in Europe. So this means almost 25,000 patients. So one patient may need 1 kilogram of immunoglobulin. That means we need 25,000 kilograms immuno per year just for these patients. So can we have it? That's also a question of plasma and perhaps to the manufacturer. So that's always the tricky part on prioritization of indications between all the use. But then, I don't know, maybe if colleagues from PPTA or would like to comment on that, perhaps. James. Okay, no, it's okay.
Maybe if I might comment.
Yes, yeah.
I mean, I think this really, we also aim to have a discussion on that with the last question, what you can see here on the slide. And I think this is really one of the complex issues where we on the one hand have the approval of immunoglobulin products and approved indications based on data, or if the data are in line with the guideline requirements and the core SMPC. Or, of course, approval is not restricted to indications that are defined in the guideline. Applicants can also apply for any other indication, but need then to submit data supporting this indication and enabling a benefit risk assessment. And we need to differentiate between approval, and that means also that an indication is approved and no longer, for example, an off-label indication, but it's not an approved SMPC is not a treatment guideline. So how to choose or how to select patients is then up to physicians and also to scientific guidelines regarding the treatment. And this is something different to guidelines defining the requirements for approval. And of course, everything we are all talking about immunoglobulins, but I think it's really important to have in mind these different aspects. And if we approve an indication, that means that data support a positive benefit risk, but how to prioritize, this is then really another aspect and needs to be done by clinicians or learned societies, for example. In some countries, there are recommendations how to prioritize in case of limited supply. But I think this is nothing we can do from regulatory side when we talk about guideline requirements and indications that can be approved.
Maybe I have a question also to Anya, because when you mentioned about HTA assessment, so for us, we always look at, when we understand it as it's an assessment of, one product, but do you also consider then as a treatment that have to be used in case of side effects? So do you look at everything together, and this would also be considered when giving an assessment on the health technology assessment perspective? So do you also look at treatment of the side effect of the given product, and this is like then taking together like a real treatment perspective of a given patient?
Yeah, because that is what makes it so complex. So it's really not that easy for HTAs to just take one group of products without differentiating between the individual products, unless we have already agreed that they are all the same. And this is this cost minimization approach. When we say we see no differences between these products, we can either say they cannot be more expensive than what we already have, because it's all the same. Or an alternative is that you put these kind of products in a tender where you say, well, everybody can give us the best possible price. This is very unattractive to the industry, and we understand that. So this is not going to help increase the capacity. But we are also bound by the fact that if there is no indication, then we are not supposed to reimburse the treatment off-label. But hospitals have this problem with the blood products that in some countries it's very strict about the reimbursement, who is responsible, and in other countries it isn't. So that it goes on the hospital budget is a problem, because it is different when it goes on the insurer side. So if it's real reimbursement, then there is control, and then we can also try to negotiate around this. But cost min is usually a simple assessment. If we would go for cost utility analysis, which is when you get let's say when the prices are too high and there are existing alternatives like antibiotics, that would be a possibility. And then we take the entire package. So it is disease specific. It's not all the blood cancers. It's very specific, every indication. Their side effect profile coming from the treatment itself. And on top of it, they have these IgG treatments that they might need or not need. And then it gets far more complex. But in the end, you could get a better price if you could really prove. And that's where we are back to, then you need a clinical study. Because if you come and you get approval with a good clinical study, then it's also much easier to get potentially a better price for your product at the HTA level, because then we would make this full assessment. But without data, we are tending to all go the road of least resistance and say, well, we make it easy for ourselves. But it's also not going to be big business. The big business in IG is in the volume. And I understand the question that is coming from Daniela. It's very clear that we have an increasing demand that we cannot fulfill anymore. And we're putting a lot of pressure on the system by not really understanding where all this IgG is actually going to and who pays for it and why we pay for it. And that is not a good situation, because in this world, I think it's very obvious that we have to prioritize. And prioritization is usually not done by EMA in itself. You just approve something and then you say, well, the rest has to deal with it outside the house. But handing it down to others in a not so well structured system, like it could be the hospitals that decide, or it could be the insurer that decides, or it could be whoever decides who is prioritized. This is not a very good situation. You want informed prioritization when it comes to this. I think this is really very important.
No, that's a good point, Anya. Any reactions to this? No, I don't see. Yes, I think we already talked about new indications where you see the clinical need. And thank you, Francesco, for highlighting some areas where additional data would be helpful. And of course, then it's always going into the question about how to conduct clinical trials. So let's hope that we have some collaboration between manufacturers so that it may be also facilitating the clinical trial perspective if there is some kind of collaboration between the manufacturer, and especially because of availability of plasma. And of course, indeed, whenever there is another use, then it has an impact overall on the immunoglobulins. So how to deal with that? And as you said, Anya, this is also something, a challenge for the national competent authorities and national countries to deal with. But of course, we also would like now to look at this. And of course, there will be this new HTA regulation. It's not yet for all products. It's only applicable for oncology and ATMPs. But I think it's also now important to look into the future and see, how the data generated not only address the requirements from a regulatory perspective, but also address HTA perspective, and they get these questions answered at the time when they have to decide and make these complex decisions, especially when treatments have to be looked at overall per indication, and you have several treatments actually given per indication. I don't know, are there any other questions? Yeah, I see something in the chat. Yeah, James has left. Yeah, any question, you can raise your hand, or any comments from the speakers on the question on the slide. Dot, I think you had a legacy hand. I don't think you have any additional questions, or?
Well, going back to the prioritization and shortages, I think we didn't mention what some physicians did here during an immune globulin shortage, and that was to lower the dose they were giving patients, but not leave them without a dose, and also to lower to lower the frequency of dosing And I do believe they probably saved, some immune globulins so that more people could get what they needed, probably.
Thank you. And I think from your side, you always had a lot of questions from FDA perspective on hypersensitivity. So I don't know, maybe we can ask also the clinicians if this is something that they see very often on hypersensitivity reaction. Of course, it's in the product information, but yes, what is the impact in clinical practice? Anything from your side? Maybe Maria.
As I was saying before, with high doses immunoglobulins that we typically do for in patients with PID when they display ITP. So we have the combo of the conditions requiring high doses IVIG or very acute illnesses. And we sometimes see systemic adverse reaction, in particular fever, EDH, and even with some hour of distance from the end of the infusion. So we typically have to manage. We have difficulty to distinguish the adverse reaction from the reason why the patient did the high doses EVIG. So typically the infection, but we have to manage with antihistaminic drug and sometimes with steroids, this kind of reaction. While for subcut, we see not very often, I have to say, local reaction that do not preclude in general the continuation of the therapy using different sites of administration.
Thank you, Maria. Any comments maybe from Yuri on the CNS indication?
I have the same impression of Maria. So concerning the subcutaneous IVIG, no many problems. There are sometimes local reaction, but they are not severe, so the patient continue the treatment without any problem. Sometimes we can have some reaction with IVIG, and sometimes they can be also serious. And as Maria said, this patient needs pre-medication with steroids or other drugs. So yes, it can happen. Anyway, I would say that there's still the incidence of these reaction are rare. So it's not so common from my point of view. So I would say that from the neurological point of view, I have no concerns about the safety. We use this drug for many years, and there are not many safety problems. IVIG sometimes are not so well tolerated concerning headache and other side effects, but I'm talking about not so, just a small part of the patient.
Mm-hmm. Yeah, I see a reason by JJ, our Professor Zaginga.
Yeah, I would like to react first on Francesco Rodighiero. I completely agree with the indication palette of IVIG for ITP. Of course, as hematologists and experts treating ITP patients, we have to find a way to better standardize and to better assess the health technology assessment of postponing the dose or giving it less easily. But the indications, I think, are set also by the EMA and at least with our insurance company. So that's great. If you talk about side effects, they are usually manageable. But of course, we're talking about huge quantities of protein, which can give hypertension. I've seen several aseptic meningitis cases, also anaphylaxis now and then. So you need close monitoring, and within our constrained health systems with a lot of problems to acutely treat patients, which is often the case in these patient groups. You need to have an admittance time at least of a day or at least a long period in a ward. The health system is under stress, and these patients need to be closely monitored for the rare, but in some cases severe side effects. It's not an easy treatment to give nowadays as acutely as you sometimes need it.
Thank you. And I think for ITP, you have also other alternatives. So maybe that's also perhaps a difference between, the indications. Okay. Karen, you had a comment?
Yes, thank you, Caroline. Just to add one element, as we're discussing about challenges there, and I'm sure you are planning to address this, but one of additional challenges internationally is also the non-full alignment of requirements for clinical development between major jurisdictions and EMA and FDA, and differences in approaches. But I'm sure you can also comment at how we will address this also in blood cluster discussions. And as I see some of FDA colleagues are here, but I think having one trial fitting the purpose of several geographical registrations may be an additional element to help industry to conduct, to produce better data.
Yeah. No, that's the kind of discussion we usually have, and of course we try as much as possible to converge our regulatory decision, certainly for safety, and as much as possible also for data generation. Of course, it makes much sense that we discuss these things so that we ask the manufacturers to do the same thing, which would be acceptable for many agencies as possible. So that's always the reason why we have these interactions with our colleagues from other international agencies like FDA and Health Canada. Yes, I see. Yapian, you have also another comment. You have your raised hand, or maybe it's Legacy.
I didn't lower it, sorry.
Yeah, it's Legacy. Okay. Okay, I think we are approaching the end of the workshop. So any last questions or comments before we close? Now it's the time. Otherwise, I think we can conclude. So before giving the floor to Daniela, yes, thank you from EMA side. It has been very helpful to get this discussion, especially from clinicians, because we really want to hear about the clinical use of immunoglobulin. It's really important that we get this feedback directly from clinical practice, and this is really important for us, especially when we revise guidelines and especially to add new indications. So we really would like to have this opportunity to have a multi-stakeholder perspective, and especially clinicians who see the patients and can see what's happening in clinical practice. So thank you from EMA side, and then I pass it on to Daniela, who can conclude the workshop.
Yeah, thank you very much. And also many thanks from my side to all of you for the very informative presentations, and also to all the contributions during the panel discussion. This was really interesting, and a lot of different aspects were discussed and perspectives were shared. And we will take this into consideration. As mentioned now, the guideline and the CORES MPC for the subcutaneous and intramuscular immunoglobulins is currently under revision, and the updated draft is out for public consultation. So we are waiting for comments until the end of May, and then we have to work on it and implement it and respond to the comments, of course. So, and this workshop was really a good opportunity to get the views of the different stakeholders, and also to have this transparent and public workshop here. I think this is really an important step. We will also prepare a meeting report that will be published on the EMA website. Yeah, and with that, many thanks again, and I close the workshop for today.
Thank you.
Thank you. Bye-bye.